Olá, bom dia, buenos dias, good morning. Bem-vindos ao Brazilian Meeting of Histoplasmosis. Nós vamos dar continuidade.
Good morning, welcome to the Histoplasmosis meeting. We will continue the activity of the other day, of the second day. The therapy mode, the sessions will be on therapy. And to begin our activities this morning, I would like to call Dr. Arnaldo Colombo, head professor at the University of São Paulo. He's also a member of the Brazilian Academy of Sciences. He's going to talk about antifungal therapies, antifungal treatment. Good morning, everyone. Pascoaloto, congratulations on the organization, you and your team. I thank you very much for the invitation. We're going to talk about three aspects of treatment, all three focused on disseminated histoplasmosis. We're going to revisit pivotal studies which supported the second topic I'm about to discuss, what the guidelines suggest. And the third will be a provocative topic as to early therapy strategies which demand further investigation.
Disclosure.
Pivotal studies, amphotericin B-deoxycholate in the 90s was what we had to treat severe fungal infections, and it was no difference with histoplasmosis. We have here a trial on AIDS patients. That's a small series. It's not a randomized trial, and effectively, not only did we measure therapeutic success, which was interesting, but also the decrease of the primary antigen as an indicator, as a marker of treatment response, which is important because many times mortality comes because of other complications associated with a low CD4. Up until the year 2000, well, in the year 2000, we had this comparative trial in which liposomal amphotericin was compared with regular amphotericin. Here we have the number of patients, and we can see that complication predictors of complications, hospitalization, and death were very similar in both groups. And patients who were lucky enough to be exposed to liposomal amphotericin not only improved faster in their symptoms, but also had a lower probability of death, or in a more optimistic way, a greater survival. This randomized trial compares in histoplasmosis of the central nervous system. It's not a common publication, but it's seen even in immunocompetent patients, showing that penetration, and we knew that already, the penetration of amphotericin and the lipid complex is lower in the central nervous system, and those patients who were submitted to liposomal deoxycholate amphotericin had greater survival. Better survival. So we learned that liposomal formation is the only one that has been tested against the conventional one, but there is no data assessing lipid complex amphotericin B. And when we take the central nervous system, clearly the performance of this second formulation was worse. The second thing, the word of triazoles. The ITRA story begins by replacing amphotericin B in the secondary prophylaxis. Imagine the drama it was to treat an individual with intravenous amphotericin, and the person needs to do secondary prophylaxis, and you maintain the conventional amphotericin doing this prophylaxis 2-3 times a week. This was a nightmare. So this is a trial showing itraconazole and its role in the reduction of relapse, and the success rate was interesting. Then replacing amphotericin in secondary prophylaxis. Then the second trial came, ITRA in early therapy. But early therapy, look, in patients with mild to moderate forms of the disease, excluding patients with central nervous system infections and patients with clinical stability. So clearly, it's a niche that is different from that niche which is to be treated with an amphotericin formulation. 59 patients assessed, a response of 85%, very low toxicity, and the fungemia control of about a week later than what is obtained with amphotericin B. There are other triazoles. Is there any advantage of using fluconazole, for example? None. This was shown in several trials. Fluconazole does not perform better than itraconazole. Well, the fluconazole availability is better, but the performance is worse. And we have data showing that it develops resistance in the prolonged use in histoplasmosis. So voriconazole has a good penetration in the central nervous system. There is a problem of metabolization, but not bioavailability. And in this comparative trial, in which we had many more patients with ITRA than with voriconazole, what is interesting is that itraconazole is an interesting drug in histoplasmosis. Many patients received itraconazole. The second point, and you can see here, look how interesting, we're talking about almost 60% of the patients with disseminated disease, 40% were immunocompetent. So don't expect only disseminated disease in patients with severe immunosuppression. There are immunocompetent patients that can develop this clinical form of the disease. 24% were HIV positive. So you can see the distribution here, a lot of symptoms in lung involvement, and ITRA was better at 50% in both groups, which consolidates itraconazole treatment in both groups. What about the guidelines? This is the PAHO guideline. These are the PAHO guidelines. What do they suggest? Liposomal amphotericin B, 3 milligrams per kilo for 2 weeks, and then you use another formulation of itraconazole. What does the what do the European Conference guidelines say? And Aisha, they say liposomal amphotericin B. If you can't afford it, then deoxycholate, and then itraconazole. And finally, a provocation. Look at this, histoplasmosis in this trial done by the Pasqualotto group, 20% occurrence in patients who had fever and one lung symptom, digestive system, or adenomegaly. These are very high rates. The French Guiana is known for having high rates. They did a primary prophylaxis trial in individuals with CD4 below 150, and they thought this was effective. I don't think we can extrapolate these data, but we can start to discuss. One evidence that the early treatment reduces mortality. This is a quite extensive trial. The author is here in the room, showing extremely high prevalences of fungal infections in HIV patients, and eventually a decrease in mortality when diagnosis is done early. And this is a cutaneous mucus involvement. It's always intrigued us, and it's true that we have different genotypes of histoplasma, different clusters, and they may have different tropisms. But this, to me, has always meant a disseminated disease that has been recognized late. This is the proof. This is done in the French Guiana. So you offer When you offer a better diagnosis, you reduce the number of individuals who present themselves in the emergency room with cutaneous disseminated disease, and then you reduce mortality. So there is a difference in tropism, but there are many late diagnoses that we can avoid. With the screening of crypto, we have understood that the antigen is active about 3 weeks before the onset of symptoms. So we have to understand whether you can do screening in everyone. And this is the opinion of the French Guiana group. Yes, we should go towards preemptive therapy, doing screening in many people. And when you do an early diagnosis, look at the mortality progression in the French Guiana. What did they do? They offered therapy, early diagnosis, and the better formulation of amphotericin, which is liposomal amphotericin. Look at how the mortality curve decreases, or in an optimistic way, an increment in the quality of life and survival of this population. Final comments? I have no question that somebody. Okay. Final comments. Undoubtedly, we need to do all effort to add new therapies, new methodologies. The government must purchase liposomal amphotericin B, and we need to provide antigens to do the early diagnosis, early therapy, and thus reduce mortality. Thank you for your attention.
Well, we've changed the program. We've changed the program. Instead of Dr. Fauci, we will have the pleasure to listen to Professor Eduardo Sprintz now. Professor Sprintz is physician associate professor with the medical school, internal medicine department at the Federal University of Rio Grande do Sul. Professor at the graduate program in medical sciences, coordinator of the HIV/AIDS outpatient clinic. He's going to talk about how to manage patients with histoplasmosis and AIDS. Thank you. I'd like to thank Professor Pascoaloto for the opportunity to be here. It's an honor for me, speaking after Professor Colombo. That's even a greater responsibility. What I'll try to do is to bring together what Colombo said with what we do in practice. I think this has already been discussed. The epidemiology of histoplasma varies depending on the environment, on the site, and when we talk about HIV infection, of course, things change as we are able to identify more our HIV positive patients and more effectively treat them, and above all, start treating them early. Things change, and when we are able to give them antiretroviral drugs, the prevalence of the disease goes down. And this can be seen in our practice. I mean, prevalence rates go down as our coverage with antiretroviral drugs increase. And Sobrive is the South Brazilian HIV cohort. Until the end of the past decade, the prevalence among us was around 5%. And in our population, it was the second most lethal fungal disease, behind only cryptococcal meningoencephalitis. So as Professor Colombo said, it's extremely important to always think or consider the disease caused by histoplasma. So let's see what we see in our daily practice, the reality of our patients, and what is our best or worst approach. So I'll call this patient Fernanda. She's 36, long-standing HIV infection, obviously poor adherence or compliance. She had been through previous treatments and she had, so to say, burned some of her drugs, particularly in genotyping, previous genotyping. She had resistance to first generation on analogs. And she had then a mutation associated with resistance to lamivudine. She came after a long time of disease with fever, weight loss, diarrhea, and that was for 4 weeks. Lab findings. She had leukopenia, anemia, and her CD4 cell count was 37. That is severely immunosuppressed. And then we were not able to identify agents without any antigen testing. In the workup, CT scan, no major findings. And since she had diarrhea, we performed a colonoscopy. There, in colonoscopy, we found ulcers throughout her bowel. We can see here. This is how it looked like. And in this column, ulcer biopsy was compatible with fungal elements. So it could be histoplasma, and culture showed that it was indeed histoplasma. So repeating what Professor Colombo said, what do guidelines recommend? So this is the PAHO guideline. Professor Colombo has mentioned it already. So what are the preferential agents for the, is it liposomal amphotericin, deoxycholate, and then itraconazole. And length of treatment will depend. For the old guys like me, we kept them on amphotericin, deoxycholate, weekly maintenance, because they would never recover immunologically. So maintenance and type of treatment will surely be proportional to the degree of immunosuppression of the patient. And as Professor Colombo said, for less severe disease, itraconazole. I think this is really important when we talk about itraconazole, because pivotal studies use the liquid formulation, which we don't have here in Brazil. And generic itraconazole in Brazil, we know that its pharmacokinetics and bioavailability is not that good. And fluconazole has many question marks, and there is one single advantage. It crosses the brain-blood barrier. I think it's really important to take that into account when we treat histoplasmosis with fluconazole. And of course, we have cases of meningoencephalitis. These are dramatic cases. The experience I have is very poor, is very bad, really. And in those cases that are less compromised from the immune point of view, we can try to treat them just with itraconazole. Well, going back to Fernanda, what happened to her? It was a patient with the public healthcare system, and liposomal amphotericin was not available, so we gave her amphotericin deoxycholate. luckily for her and for us, she had no toxicity to amphotericin. And even though guidelines recommend at first treatment for 2 weeks, we were not confident enough because, after all, she was tolerating the treatment. So 3 weeks treatment, so 3 weeks amphotericin deoxycholate IV, and then maintenance treatment with itraconazole. And she had great improvement. Like 3 days after that, she was really much, much better. And then what should we do? For how long should we have maintenance therapy? For how long should we follow? And whether we are going to try to prevent recurrence. This will always depend on the compliance of the patient. We know that late presenting patients are hard to treat. And we, through initiative by Diego Pasqualotto, we are trying to implement antigen testing to try to have an earlier diagnosis, as Professor Colombo said, in order to try to prevent disseminated disease. Well, I've talked about histoplasmosis. What about HIV? We have to treat HIV. We have to stop this threat. For histoplasmosis, I think it's a bit easier. We're always afraid in late presenters with advanced disease of the immune reconstitution syndrome, which sometimes, depending on the organ involved, can kill. We know that cryptococcal meningoencephalitis and CNS TB are associated with immune reconstitution that may be life-threatening. In the case of histoplasmosis, this is not the rule. Immune reconstitution with antiretroviral drugs, we hardly see that with histoplasma. So 2 weeks after initiation of histoplasmosis treatment, we started treating with tenofovir, lamivudine, darunavir, and ritonavir. I think it's worth it to highlight that we use as a trick to improve the bioavailability serum levels of itraconazole, we use ritonavir. Ritonavir decreases metabolism, liver metabolism of itraconazole, and leads to better serum levels, even in generic formulations of the drug. Well, to close the story, which has a happy end, which is not always the case, Fernanda didn't have immune reconstitution. She changed her life. She had an excellent response to treatment. She had then undetected viral levels, and 1 year later, we discontinued itraconazole. She had CD4 levels over 200 and undetected viral load. And now, 3 years later, she came to the office. The treatment was changed in order to improve tolerability, decrease drug-to-drug interaction. She is with tenofovir, lamivudine, and she is very well. We can discuss if that's the regimen, if we can remove tenofovir, for example, to decrease nephrotoxicity. In February, she had undetected viral load, and CD4 was almost 400. For those who know me, this is one of the slides I show. In medicine, common sense is key. And we have to know how to take the tractor in the most balanced way possible. even if very slowly, it can go the right direction. Thank you very much, and I'd like to thank you for the opportunity.
Obrigado, Eduardo. E agora para falar sobre a toxicidade renal dos
Thank you, Eduardo. I will now talk about renal toxicity.
que é médico infectologista do Hospital São Lucas
Of amphotericin B
do Hospital de Clínicas de Porto Alegre, do Hospital Moinhos.
from the Porto Alegre hospitals. He's an effective member of the Clinical Mycology Committee, professor of medicine at PUC, and head of the department at PUC Rio Grande.
Bom dia a todos. Obrigado, Flávio, pela introdução. Agradeço novamente o convite, Alessandro, a participar.
Thank you very much for the invitation.
E agora nessa sessão vou falar sobre toxicidade de anfotericina B, diferentes formulações. Eu acho que é um assunto que é importante, complementa.
All right, we'll talk about renal toxicity of amphotericin compounds. I think it's something that will complement the previous presentation. We'll have certain, we'll say certain things, and then Francelize will talk also about amphotericin B. These are my acknowledgements. As has been said here, and I think it's important for us to stress that amphotericin B is a cornerstone in the treatment of histoplasmosis in the very many forms of the disease, of course, mainly in the disseminated disease. And as has been mentioned yesterday, and I thought it was very interesting, a sense that amphotericin deoxycholate is a poison and it should not be prescribed, and I agree with it, but we know that it has a lot of, it's a very important medication. I know there is nephrotoxicity, but lipid formulations then offer a much safer alternative. Among the adverse effects, and I'd like to mention the others so that we don't forget them, we have acute effects, that is those that take place at the time of infusion. We have acute infusion reactions, which may have some repercussion depending on the patient. These reactions, I mean, and we have nephrotoxicity, hematological toxicity, cardiac toxicity as subacute events. So these are episodes that happen after the treatment and have consequences, which we will see during the presentation. The incidence of the oxycholate and nephrotoxicity in the different series will vary between 49 and 65%. So you have an average of 50%. It's almost like tossing a coin up in the air. If it's head, you have toxicity. If it's tails, then you don't. So it is really heads or tails because we do have risk factors depending on the dosage, length of treatment, previous nephropathy, and the use of nephrotoxic drugs altogether. But not always can we correctly identify who is the patient who will have toxicity. Many times a patient with no risk factors has toxicity to amphotericin. The mechanism that we know, actually there are two mechanisms. One would be direct vasoconstriction, a toxicity that straight to the glomerule, and tubular dysfunction, that is dysfunction to the tubular cells in the kidney, causing what we call a tubuloglomerular toxicity. So this will generate a signal to the glomerule saying you have to filter less, and this ends up potentializing the toxicity of amphotericin, though they feed back on each other. The cellular molecular level, we'll talk about apoptosis, especially in the tubular cells. This, of course, will cause hypokalemia and hypomagnesemia. And we have greater affinity of the oxycholate formation by the LDL of the glomerular cells. So we have a greater expression of LDL because that LDL actually is the cholesterol that we have in these human cells. And it is similar to ergosterol, which is the target of amphotericin. Thus, we can have this toxicity also for the human cell, specifically the tubular cells in the kidney. But there is a lot of nephrotoxicity, as I said, 50%. But okay, all we have to do is remove it, and then the person releases creatinine. Many times we think that way, or if if the patient worsens, I go to a lipid formulation, but it's not how it happens. Nephrotoxicity, because amphotericin has an impact. It has an impact in the hospital, the length of stay, cost of dialysis, because the patient will progress to dialysis. It'll generate cost in the monitoring of this patient, the assessment by a nephrologist, more frequent medical visits, all that generates costs. So the nephrotoxicity does have an impact to the patient and to the healthcare system. And these are the consequences to the system. The consequences to the patient are also dramatic. We increase mortality of patients, and I'm talking about associated mortality. This patient worsens, he will eventually die from another cause while he was too long in the hospital. Then he catches a hospital infection and dies. So we do have impacts regarding nephrotoxicity of amphotericin. These are two trials. This one compiled data from hospitals in Europe, several hospitals, and it increased nephrotoxicity, increased the risk of death in patients in almost threefold. So it's really something significant. It's not something trivial that I just removed the drug and it relieves creatinine. No, it has a very big impact on patients. Well, I talked about deoxycholate. I said it was bad. It was a venom or poison, as has been said before. But is that news? A piece of news? No. I'd like to say more. I'd like to say that among the lipid formulations, we have differences. These are the three lipid formulations that we know: amphotericin B lipid complex, amphotericin B, the colloidal dispersion. This one we don't have in the Brazilian market, at least. And the one on the right, liposomal amphotericin B. Just by the picture, and I will not get into details because of time, I'm not going to mention pharmacokinetic and all these characteristics, but you will know that they are different. Actually, the lipid formulation will lead amphotericin in a more selective way to the site of action where the fungal infection is taking place, thus avoiding toxicity. So I'm carrying it over to where it is necessary and where it could cause, there could be toxicity. And the way they load is different. The liposomal is different from the lipid complex. If we take both ends here, in the lipid complex, we have more of a tape-like formulation. It's almost like a rubber tape, all coiled up. And the liposomal here on the right is carrying over the amphotericin B molecules. And this actually, we have few data on the difference between them, as I will show you, but we have a lot of information already regarding minor toxicity or lower toxicity of lipid formulations as compared to deoxycholate. I think it was said here, Professor Arnaldo mentioned, but liposomal amphotericin has much more data on it than deoxycholate, but still there is a discussion as to which populations would deserve a liposomal amphotericin directly, or if there would be some degrees, some differences. I will show you this trial on histoplasmosis. Dr. Arnaldo presented it. I think aside from the difference in efficacy that has been shown, Professor Arnaldo showed lower mortality in the group that used liposomal amphotericin. I have bringing here the nephrotoxicity aspect, which was also different, 37% with deoxycholate as compared to 9% with liposomal amphotericin. So this was a statistically significant difference in this trial. Now let us try to compare the formulations among themselves or between themselves. Here we have this trial, a randomized clinical trial, 244 patients with febrile neutropenia. These are one of the few trials that we have that compare the lipid amphotericins. I consider this to be the most important one. It assessed 3 groups, 2 with liposomal amphotericin B at different doses, and 1 group with lipid complex amphotericin, 3 and 5 milligrams kilo, and then for the liposomal, 5. So difference was very different. You can see the ambisome group nephrotoxicity, which here was measured in terms of multiples of increase in creatinine, 29, 26%, and Abelset, for ambisome and Abelset, 63%. And in terms of creatinine, the difference also appeared in an important way, as you can see in the slide. So this clinical trial with 244 patients showed this difference. Well, other trials, other few studies followed, and actually said they had different methodologies. What they tried to do here, this group back in 2010 tried to do a meta-analysis bringing together all studies which had assessed different formulations of amphotericin as regarding nephrotoxicity. And when we compile all these 8 studies, we have greater risk with the lipid complex amphotericin and less toxicity with the liposomal formulation. But when we do a meta-analysis, we run some tests to see whether there is heterogeneity, if there is, because I am comparing different things. They are studies with different methodologies. So this affects my end result. What did they do here? They did a meta-analysis technique that we do. It is a sensitivity analysis. They remove trials and they redo the comparisons. And removing several trials and studies, as you can see, they ended up removing the most important one. They saw there was no difference, and they concluded that there was no difference between the formulations. Look at this. I know you can't read this chart well, but what I want to show in this square, these are the only 2 randomized trials, and here the study that I showed you in the beginning showing that difference, and these are other trials that showed difference as well. And what did the meta-analysis people do here? In the beginning, in favor of ambisome, less nephrotoxicity, and when we exclude some studies, especially the INGERD study, which was the most important clinical trial, they end up showing an absence of difference between the formulations. I brought this meta-analysis in order for us not to interpret it as a very straightforward reading. I think we have to look carefully into the information and try to interpret it in the correct way. After that, and I would like to show you now some data from our own group, just to close my talk, we have this study from a network of 150 hospitals in the US, and they had a similar number of patients here. There was a big network. They had a multivariate analysis analyzing for nephrotoxicity, and they saw that it was independently associated with the use of the lipid complex amphotericin. We did this study in 2014 at the Santa Casa Hospital in Porto Alegre, and it's an important study because it has more than 400 patients, and it was done in a real-time context. It's a retrospective cohort, and this trial involving 25 patients with histoplasmosis, and I will show you something specific of these patients. It showed that we had more nephrotoxicity with the amphotericin deoxycholate, but more than that, it showed that the amphotericin liposomal was liposomal amphotericin was a protective factor for the occurrence of severe nephrotoxicity, which was not true, or at least was not significant for the amphotericin B lipid complex. So this trial, as I said before, it had 25 patients with histoplasmosis, and this is something that was mentioned yesterday too, about transplant patients. We had 4 patients in this group of 25 who had transplants, 3 kidney transplants and 1 lung transplant. So these are the divisions, and we saw based on that, and it was evident and obvious that we had more nephrotoxicity with amphotericin deoxycholate. And here what called my attention in this subgroup of histoplasmosis, we did not have the occurrence of nephrotoxicity with the liposomal B amphotericin. Of course, the N is different. It's not a direct comparison I'm making. It's just a piece of data among the histoplasmosis patients which call our attention. Now my time is coming up. My time is up. So I can only say a few things. And how can we use amphotericin in a more safer way with less adverse events? This is a study published on the New England Journal of Medicine, and its ambition, cryptococcosis, but it showed that a single dose liposomal amphotericin is as good as traditional treatment of cryptococcosis with amphotericin every day for 14 days. Aside from being as good as, we had less toxicity in the group that used a single dose as compared to the control group. And we have as a perspective, right, Alessandro, this study, which is still underway. I think our recruiting was ended, I think, about 2 weeks ago. So soon we will have some information to tell you and to publish. This is a single dose study for histoplasmosis, single dose of liposomal amphotericin. So it is in our radar already. It is a perspective, and it's a possible strategy to reduce nephrotoxicity associated with the use of amphotericin here in the treatment of histoplasmosis. My conclusions, I'd like to say that we do have an important role, as we've seen throughout this meeting. Amphotericin B has a key role in the treatment of histoplasmosis. We do have important differences between formulations, and actually we have to consider all of that. We have to look at the patient, look at the clinical syndrome to make a good choice, a good treatment strategy. We do have for histoplasmosis much more robust data as to the regarding the liposomal amphotericin, the liposomal formulation, and it's been shown in the guidelines as well, and new strategies, especially the single dose strategy currently is under assessment, and soon we should have some information. Thank you.
I haven't heard the bell yet today. I think that all our speakers are really sticking to the time they have. Now I have the pleasure of calling Professor Francilise Bride Cavazin. Francilise is a pharmacist, has master's degree in microbiology. She is pharmacology professor at the medical school, Pequeno Príncipe Hospital in Curitiba. She's also a pharmacist with the Physicians Without Borders, and she collected data on 2,000 patients who were treated with different amphotericin formulations all over Brazil. And she is going to give us a snapshot of the around 260 patients who had histoplasmosis and were treated with amphotericin B. So she's going to show us this outstanding work. Thank you. First of all, I would like to thank you. This is a beautiful meeting. Thank you, Professor Pascalotto, so much for the invitation. It's a real pleasure to be here and share this time with so many people I admire who are experts on this subject. So thank you very much for the opportunity. Dr. Flavio has already talked a little bit about my presentation. I have no conflict of interest to disclose related to this presentation. Well, this is my PhD study, and Dr. Flavio is the advisor at the Clínicas Hospital Complex in Curitiba, state of Paraná. We are conducting this multi-center study with 10 centers. It's a large study with many different partners. Dr. Diego is here, Vidal, Dr. Cassia. It's a very nice partnership that is going on, and soon I hope to have this data available so that we try to answer a few gaps, particularly regarding the lipid complex, because that bit is still missing. So for this, multi-center study, we have almost 2,000 patients. It hasn't been completed yet, but for this meeting, I was given the mission to show you already some numbers talking about histoplasmosis. So out of the 10 centers, 7 have patients with proven histoplasmosis, a total of 1,457 patients from these 7 centers. And we have 220 patients, so 15% of them have been diagnosed with probable or proven histoplasmosis. This is the distribution of the pointer is not working. No problem. So this is just for you to understand. We see a difference in the number of cases. It is important for you all to have this clear. Okay, this is a snapshot, and the inclusion criteria for this study was, this is a retrospective study, I should say that too, but so they should be admitted to a hospital and they should be on at least 3 doses of amphotericin B, any of the formulations. That's why we have fewer centers. Dr. Cassia will be talking about this huge number they have at her center, but yesterday we were talking and she talked a little bit about it. She is referred from over 200 cities, so people are referred to her center coming from many different cities, which is not the reality in every center. So these are centers or hospitals that accepted to be part of this study. So when we talk about 7 out of 9, it's because we had 2 individuals with probable histoplasmosis who were treated with amphotericin B, and of the 9 treated with ampho, 7 had probable or compared, or proven or probable or proven disease. So patient groups were broken down into those who were HIV positive and non-HIV, 192 and 28 respectively, and lipid formulations or conventional ampho B formulations. It's really a shame that the pointer is not working. Sorry about that. So yesterday, this has been discussed here. Culture and histopathologic testing are still the methods most widely used here in Brazil. Serology and antigen testing, we in our hospital, we don't have these methods available, and this is the reality also in some of the other centers. So from these 1,497, so out of these 1,497, looking at the 220, we have some information. For example, mean age of this individual, almost 41 years. The Brazilian Midwest, where Dr. Cassia's center is, really stood out in terms of the number of individuals among these 220 and HIV positive patients. Well, as you can see, we have many more HIV positive patients included there in this group than non-HIV patients. We see here the difference in terms of amphotericin use, including both, so lipid complex accounts for less than 10% of the individuals who were treated with amphotericin. And out of the 220 patients, 56 were on a azole during their treatment with amphotericin B. We haven't looked at that yet, but we are trying to understand, because we don't have guidelines suggesting this association between amphotericin B and azole. So as I was asked to give you a snapshot what is going on in relation to conventional amphotericin. So the oxycolate, the center that, well, all centers have it available, but in the Brazilian Midwest, it was more used. So 164 were only on the conventional amphotericin B formulation, over 74%, 143 completed without discontinuing treatment. That's 21. 21, when we look at the reasons why treatment was discontinued, around 66% were related to renal function. In addition to these 164 individuals, additional 28 individuals added to these 164, they started being treated on conventional amphotericin, but a request was made to change formulation. So over 70% they migrated from conventional amphotericin B to lipid complex, infusion events, so acute infusion reactions. We had that in 23 patients, and the main events were fever, nausea, vomiting, and others. Use of pre-medication. The use of pre-medication, this is when the physician writes in on the prescription that they want the patient to be on dipyron or other drug to get amphotericin B, not only steroid, something else, but they say that 30 minutes before amphotericin B, they should get this other medication. So steroids, in the case of the oxycolate, and dipyron were the most widely prescribed pre-medications. And in 33 cases, therapy could not be completed because the patients died. So they died during treatment or one day after completing the treatment. So, and that was accounted for 20% of the patients. For liposomal amphotericin, well, the number is very small. It's really hard to make a comparison with that number, having that number of patients treated with liposomal. But at São Rafael Hospital, I think 3 of the 5 were there at her center, São Rafael Hospital. All of them completed the treatment, no discontinuation, which is in agreement with what Dr. Fauci mentioned. And liposomal formulation, no toxicity. And in addition to these 5, additional 6 is started on liposomal formulation, but then they migrated to a different formulation. Probably this has to do with the Ministry of Health. It has to do with supply of the different formulations, and over 80% migrated from liposomal formulation to a lipid complex formulation. No reported infusion reaction. 66.7% received some pre-medication to avoid these reactions. And here we had more antihistamines and dipyron prescribed. This is a difference in terms of pre-medication when compared to the other formulation. No patients died during treatment or one day after treatment completion. And the ABLC, the lipid complex, 16, all of them completed the treatment without discontinuation due to toxicity or any other cause, and one individual migrated from the lipid complex to liposomal amphotericin B. And this is interesting because we had 8 individuals who had infusion reaction, acute infusion reaction during infusion, but 75% of these patients used some pre-medication. That's interesting. Of course, we have to look at that very carefully. And I'm giving you a snapshot of these 220, and here we have 16. But when I look at my database, almost 2,000 patients, and I have many more patients on lipid complex, we check if the use of pre-medication is more recurrent or more common, and also the occurrence of infusion reactions. So antihistamines, followed by dipyrone and steroids, these were the pre-medications of choice. And in 3 cases, slightly less than 20% therapy or treatment couldn't be completed because individuals died during treatment. So to give you some numbers, before I showed you 192 HIV positive patients, non-HIV 28 patients. Out of these 28 who would be eligible to go straight to a lipid formulation because they are non-HIV according to the Brazilian Ministry of Health, in spite of that, 18 started on the conventional Ampho B formulation, and only 10 started being treated right away with lipid complex formulation. And out of those, 11 migrated so that they continued with a lipid formulation. So out of the 7 who remained on conventional amphotericin B, 4 had to discontinue due to toxicity, and that was 57%. And on the other side, out of the 192, 181 were on conventional amphotericin deoxycholate, and 24 had to change to a liposomal formulation. That's around 11% of cases that had to discontinue treatment due to any given cause. Now, comparing the 3 formulations, I think the bell will ring for me. I can feel that. So comparing the 3 formulations, I have some interesting data to share with you regarding infusion reactions and the use of pre-medication, comparing these different amphotericin B formulations. What stands out here is the lipid complex formulation. Discontinuation of treatment was more often when the patients were getting amphotericin B deoxycholate, which is expected. Dialysis, 16 patients from conventional formulation, deoxycholate, and the physician says in the record that it was because of amphotericin B was used. There are many situations where we see that in the medical record saying that the patient was already on dialysis or already had another condition. Of course, this has to do with proper follow-up by the attending physician. Use of electrolyte replacement too for amphotericin B deoxycholate, more cases of electrolyte replacement, and length of stay when they are first admitted to up to their discharge, so length of stay. We don't see a significant difference in terms of length of stay, but it's interesting, particularly in lipid complex. The last time in the hospital, this means lower cost, and thus this is very relevant. And as I've shown you, deaths or mortality during treatment for amphotericin B deoxycholate, okay, it's proportional because we had 16 on the lipid complex, but anyway, around 20% mortality during treatment for both formulations. Final remarks. We have the patient profile. Most of them were males, mean age 40, HIV positive, use of lipid formulation less than 10%, change of formulation in 35 cases, most of them changing from deoxycholate to lipid complex, infusion reactions. Comparing deoxycholate with the lipid complex, there was a significant difference, and in this case, showing greater incidence for the lipid complex, use of premedication too, the number of individuals who received premedication, and also putting all formulations together, hospital discharge 73%, deaths 27%, and during treatment, out of these 27% of deaths, around 19.4% was during treatment or 1 day after treatment completion. Thank you very much, and I'm available for questions.
Obrigado, Fran. Bem, dando continuidade, tenho o prazer de chamar o professor Juan Luis Tudela.
I would now like to call Professor Juan Luis Tudela. Juan Luis Tudela was the founder of the reference mycology lab in Spain, chief of the Salud Carlos III Institute. He is a member of several international associations. Former president. He's from the European Community of Accessibility Tests. Currently, Professor Tudela is connected with GAFI, Global Action for Fungal Infections. Thank you very much. I will speak in Spanish. I would like to thank Alessandro for the invitation. I am not a specialist in access to antifungal therapy. At the end of the presentation, please tell me sincerely what you think. Here are my conflicts of interest. I haven't been paid anything in the last 10 years, so I don't have any disclosures to make in this talk. We know the vision is a new
So these countries should be able to treat fungal diseases, and this is in agreement with WHO. Diagnostics and medicines for diagnosing and treating fungal disease everywhere in the world. And in the next 5 to 7 years, we want to have 100 countries with availability of all the drugs and access to diagnosis. Good network of 100 country ambassadors. Right now we have 66 in 67 countries. We are trying to put together a global data center to improve surveillance and advocacy, and we are very much interested in artificial intelligence, and we are developing AI program, and we are developing an algorithm to be able to read with a cell phone and to have it in the cloud, and starting with access to treatment. These are all the drugs approved, all antifungal drugs approved by WHO. We have contributed with all echinocandins and other drugs. They are available in addition to treatment for pneumocystis. Regarding the essential diagnostics list, microscopy, histopathology, culture, and blood culture, indigenous species and antifungal susceptibility testing, pneumocystis PCR, and cryptococcus antigen, PCR or other methods, histoplasma antigen, aspergillus IgG antibodies, and aspergillus antigen. So basically, basics for mycology has been recommended and approved. Now we have to implement it in all countries. What are the problems of pharmaceutical companies to register drugs? There are a number of problems, and depends on the countries where they try to register these drugs. First, the size of the market. The bigger the market, the more they register. Financial opportunities. And one of the aspects they really complain about is that there are very complex regulatory requirements, and that there's a lot of red tape. They complain a lot about that. Policies on price transparency, and they also want to know whether there are competing drugs in the market, economic sanctions, and of course, the issue of political instability. But this is the map. This is GAFI's map, access to antifungal. So we see that Ambisome is in virtually every country in the world. So the main problem is that you don't have it because it's too expensive. Adverse events can be actually much more costly than the drug price itself. Thus, we have really to think and carefully look at this situation. Are there solutions for the price issue? Of course. We have, for example, patient assistance programs. For leishmaniasis, for example, $10 million have been donated to get Ambisome for free, donations, public-private partnerships. You can have technology transfer, and countries can produce their own drugs and tiered pricing. So the more you consume, the cheaper it will become. So basically, this has to do with political will. Politicians have to bet for something that has been scientifically proven. But what can we do? What can the fungal disease community do in order to get global access to diagnosis and treatment? I'll talk about, well, fungal disease is something very complex. The first thing is that it's usually hidden in underlying disease, so it's very hard to diagnose them. There's lack of health workers training. We don't have, so physicians don't even consider fungal diseases, and thus no diagnosis is made. We have global exposure. We are all breathing in or inhaling aspergillus right now. I hope nothing happens. And then we also have environmental and zoonotic pathogens. Clinical practice is based on empiricism. In many countries, there is no diagnostics available, and unfortunately, we have a much higher burden of the disease in patients with limited resources. It is really hard to have produced drugs against fungal diseases. It's much more complex than drugs against bacteria. So RCTs are very complex, and it takes many years to perform these trials. Same compounds are used in the environment and in humans, and thus antifungals resistance is going up. And we have this eternal question, and I'm really against this question that is asked over and over again. How many fungal diseases do you have so that I give you access to? It's important to know the disease burden. Disease burden is a tool in public health policy, but it's not a tool not to provide people with diagnostics and treatment. This is a policy just for you to know where you have to have diagnosis. Should it be in a reference lab or in primary care? But it's not a tool to deny treatment to diagnose, deny treatment and diagnosis. So what is first, the chicken or the egg? No access to treatment, and then no access to diagnosis, and no access to burden of the disease. We have this never-ending problem. Without diagnosis, medicine is witchcraft. It's witchcraft. So I will give you an example, histoplasmosis. Before HIV, there were many cases were cured on their own, and some cases were detected in labs, in very good labs. In Spain, we didn't have any way of diagnosis imported histoplasmosis case because no lab were able to do it until we started one, and that was back in the 1990s. Then we had HIV, more severe cases, and then we had access to TB diagnosis, but no access to diagnosis of histoplasmosis. Because everything was TB for a long time. Everything was TB. Of course, we have no disease burden, and then TB. What else? This is what George Clooney said. And this study with Guatemala, with the new commercial antigen test, we were able to diagnose 35% more disseminated histoplasmosis and 32.7% of cryptococcal meningitis cases. You cannot miss these cases just because you don't have information, no diagnosis. And We have the political organization of the world in nations, but bugs do not understand borders, and they will go everywhere. So we need One Health. We should look at this One Health issue and forget about maps. We wonder, should we repeat the same epidemiological study in every country in order to have access to diagnosis and treatment? I'll give you another example. In country A, they made an effort, conducted an epidemiological study, and they know what the disease burden is. In countries B and C, they have the same underlying diseases, HIV, leukemia, COPD, and they have the same fungi in the environment, but they have detected some cases. It isn't necessary to conduct an epidemiological study. These people from the computer science department in California, they need algorithms for knowledge transfer. If in environment A, epidemiological study was conducted, and in environment B, which is totally different, they do passive observations, but no experiments. The problem is, if we can bring A and B together, if there is causal relationship between both, if you cannot bring them together, you cannot have this knowledge transfer algorithms. But we can do that because histoplasma is in the environment. Passive observations have already been done virtually in all countries in the continent. All countries have HIV cases. All countries have cases of advanced HIV disease, and the HIV epidemiology is known. So I would apply the algorithm, would see the results and get access to diagnosis and treatment right away. And with that, we could save money, time, and lives. We clearly need fungal diseases without borders. And to close, this is my own proposal in this last slide. I think that fungal diseases, we need big data for fungal diseases. We need big data for fungal diseases. We cannot miss one single case of a patient who has a fungal infection and have observational databases with proven cases and controls so that we can randomize. In observational databases, real life is not an RTC where everybody's followed. This is a reality, and you can do randomization, and then you can study it using machine learning and causality, reaching conclusions. And I think we should have biobanks. We should get DNA from patients. We should get microbiome from patients with proven cases and controls to do the same thing, randomization, and use the latest statistical techniques and AI. We should keep the strains to see whether they have resistance. We should sequence them, we should type them, and we should have clinical samples of proven cases and controls so that the new diagnostic techniques can be standardized as fast as possible. And finally, in mycology, we should also have digital imaging databases, images of skin lesions, any lesions, and this is where AI is really advanced, images from proven cases and controls so that we can use neural networks, machine learning, so that we can make diagnosis much faster. Taking all together, DNA, host DNA, microbiome, strains, we would put that in, feed that into the observational database and analyze all this with these new tools. Finally, some advertising. Access to treatment, I think it depends on political will, and I think what we should start doing is big data and AI. I think we should apply instruments to decrease prices and speed up the registration process, and we should think about decreasing the cost and, above all, the length of studies. Well, finally, marketing of myself. During the COVID-19, I was so bored that I wrote a novel. Right now, it's available in Spanish and English and Amazon, and all the money we get will go to Gafi. You don't have to read it, okay? Just buy it, and it will help us fight against fungal diseases. Thank you very much.
Graças, Juan Luis. Quero agora chamar o Dr. Zenóbio Soares, que é médico.
I would now like to call Dr. Zenóbio Soares from Porto Alegre. He works with HIV/AIDS here in the Health Secretary of Rio Grande do Sul. He's going to talk about the optimization of antiretroviral therapy in the era of integrase inhibitors. Thank you. We had a last-minute change on the schedule here, and I had to decide for a non-promotional presentation. Just so you know, I am a doctor from the pharmaceutical industry. I do work for GSK, and the topic that was chosen was challenges in the HIV care in 2022. These are my disclosures. Currently, I am employed by GSK. Antiretroviral therapy has changed our world in the last few years. As we can see here, more than 25 million people who live with HIV have access to antiretroviral therapy nowadays. These are data from 2019 showing the increase of access of people living with HIV therapy to antiretroviral therapy in the last 2 years. And this was followed by a decrease in mortality. This decrease of more than 50% since 2004. And in 2010, we had a decrease of 33% in mortality. This is the progression of the cases detected per year in Brazil, and we can follow detection rates from 2012 to 2020. We had an important increase in these detection rates, and the rates are followed by, just so you know, let me check the pointer here. These detection of new cases has been decreasing in the last few years. As we can see, there is an important decrease in 2020 according to the data from our most recent epidemiological bulletin or newsletter. And this nowadays we have observed an intersection of epidemics. With the arrival of the COVID-19 epidemic, there was in the intersection with the HIV epidemic, what we noticed was that in the beginning of the epidemic, we had a reduction of diagnosis and in the start of antiretroviral therapies. So what we learned with HIV in the HIV pandemic, we also learned in the COVID pandemic, but inequalities increased and there was a great impact caused by this social distancing. The map already proposed some more ambitious goals. The UNAIDS proposed some goals to be achieved by the year 2025. This would be a summary of our epidemic in Brazil. According to the last epidemiological newsletter, we would have 936,000 people living with HIV in Brazil today. Only in 2020, 32,700 new cases detected with 10,400 deaths. This would be the challenge of our national scenario, the situation of these 936,000 people living with HIV in Brazil. What is the situation? Now we would have 116,000 people living with HIV who do not know they have the infection. And in this scenario, we also have 154,000 people living with HIV who do not do antiretroviral treatment. So this shows our epidemiological challenge. The fact that we have to implement many things, that we have a lot of room for growth in terms of our epidemiological diagnosis, the healthcare services, antiretroviral therapies in the long term, all that needs to be improved. In this slide, we have data from a meta-analysis showing exactly what we have been observing in the last few years. These are older data from 1995 to 2010, and they show that the large progression, the large advance we've seen in antiretroviral therapy, these high virological rates in the last clinical trials, we can see them, and the safety and tolerability data leading to less treatment abandonment, as you can see on the right. So even with the improvement of ART antiretroviral therapy and efficacy data and everything, patients still abandon treatment, and the causes are conditioned to several factors, individual factors, systemic factors, and factors that may derive from the very healthcare system. So there are many reasons that patients find to abandon antiretroviral therapy in the long term. So there is the need for us to optimize this therapy. There are many reasons to optimize therapy and treatment, always trying to treat toxicities. This is what we do in our daily outpatient clinic. Reduce toxicities, always trying to keep control and reduce virological failure, improving patient adherence, preventing drug interactions, and eventually improving the quality of life of our patients. Strategies to optimize antiretroviral therapy in the long term. We've been looking for new co-formulations, combined fixed dose, improving adherence, new reformulations of these medications, drug adjustment, the arrival of new drugs, greater tolerance, new strategies, maintenance, intensification of therapy, and even disintensification of the therapy of antiretroviral therapy. The good news is that in the long run, what we can see is an increase in the life expectancy of HIV-positive patients, as these data show, published in 2020. We can see an important increase in the life expectancy, showing that a patient who is diagnosed at 21 years of age has a 55 years life expectancy, which is a long time for which is a long time. What we can observe here is that even if we control the viremia of patients, the microinflammation process continues in a chronic way, and it conditions the patient to an early appearance of many comorbidities. The early appearance of cardiovascular disease, reduction of bone minerals, and the appearance of some types of cancers. These comorbidities and their increase has been demonstrated in several studies. We have a Brazilian study conducted at CRT in São Paulo and Salvador, showing an increase in comorbidities when we compare this prevalence to patients who are HIV negative. So the secret nowadays, in terms of the control and the success of antiretroviral therapy, is our trying to anticipate the appearance of these toxicities and comorbidities in patients. And we know that many of these comorbidities many times were only known after a long time after the use of antiretroviral therapy. For example, the discovery of some toxicities was only notified or recorded sometime after the medication registration, as was the case of zidovudine, which happened 12 years later, 12 years after it was registered in the FDA, in myocardial infarction, 10 years after that. So we try to establish strategies to try to reduce exposure of patients to antiretrovirals. So what would be these strategies? Many have been tried. Dose reduction some time ago. In some countries, they use favirenz in a more reduced favirenz. In Brazil, We use a dosage of 6 milligrams a day in some countries, 600, excuse me, and in some countries it has been reduced to 400 milligrams. Also discontinuing the boosting agents like ritonavir for some time. Tazanavir has been used also without ritonavir in some specific situations. In other situations, we've been trying to reduce the number of drugs and the exposure to these drugs. Therefore, well, now bringing here to this discussion a new challenge. The challenge, we talk a lot about the management of drug interactions. A critical patient with histoplasmosis or tuberculosis after hospitalization, they have more drugs to take. They have therapeutic or schemes that have a greater risk of hepatotoxicity, nephrotoxicity. What we have been trying to manage are drug schemes which will be friendlier and which will not be so much associated with these antiretroviral drug schemes. So they will use therapy for histoplasmosis, and it may last a year. And these drugs may interact with the antiretroviral therapy drugs. One other challenge is for us to learn to listen to our patients, because we know that many patients currently show ever more during the visit the concern that they have in reducing the severity and the frequency of these adverse events, as we can see here. 45% of the patients are worried about reducing the frequency of side effects and the severity of these side effects, and 35% also demonstrate the need to reduce the number of pills. What could we say in terms of considerations in the modern HIV era? Taking into account the accumulation of these comorbidities, adverse events, the populational aging and polypharmacy, we also have the information that nowadays we have antiretroviral schemes that have high efficacy, and the efficacy was very much increased after integrase inhibitors were introduced. So it's always recommended that antiretroviral therapy be started, and most people always using schemes that are based on integrase inhibitors. So in Brazil, we have the same challenges. We have to promote an increase of testing and diagnosis rates, and try to promote adherence, connect this patient with the healthcare service, ensure that these patients receive treatment and achieve a long-lasting virological control. We have to fight the stigma, and we have to take care of the more vulnerable populations who may be infected. Thank you.
Como a última apresentação desta sessão, eu tenho a satisfação de chamar a doutora Marilene de Mello, aqui do Rio Grande do Sul. Ela vai falar sobre...
Now I have the pleasure of calling Dr. Marilene de Mello. She will talk about the management of co-infections. She is a researcher in this clinical trials. She's an infectious diseases specialist. She works at the Conceição Hospital in Porto Alegre.
Bom dia. Talvez todo mundo já esteja pouco cansado. Eu vou tentar ficar dentro do meu...
Good morning. Maybe, I guess people could be a bit tired, so I will stick to my 15 minutes. I have no conflicts of interest. If those who don't know me, I am an infectious disease specialist. I work with HIV infection I have worked in that field for many years. I am a doctor from the Conceição Hospital. It is a large general hospital, 100% public healthcare system in the northern region of the city, and it helps the more needy population. You will notice in my talk that these are people with very advanced disease. Okay, let's talk about the epidemiology of these two diseases. In the last years, with the increase in HIV, two diseases that were not so much studied by us came up, histoplasmosis and AIDS. I speak of histoplasmosis first because one of our very first cases was exactly a case of histoplasmosis, and we had to learn and deal with these two diseases here in our region. With the immunosuppression caused by the CD4 decrease, we can see that opportunistic infections are many, multiple, concurrent, and very severe, and their management requires high diagnostic suspicion, efficient methods of diagnosis, and the great knowledge of the drug interaction when we manage these diseases. Histoplasmosis, as we know, is a cosmopolitan disease. It is present in over 60 countries, therefore in the whole world, as you can see. And here we live in an area of high density for both diseases, both AIDS and histoplasmosis. We had a study with histoplasmin in the 1990s here in the South, which showed a positivity of 84% in the Jacuí River Valley in the city of Cachoeira do Sul. We know that in the Americas, every year there are at least 15,600 new cases and 4,500 deaths among people living with HIV. Among people living with HIV, the most important clinical presentation is the disseminated disease. And I will open a parenthesis here that the disseminated disease to us in our region is translated by skin lesions. And every time we have a skin lesion, we have a disseminated disease, a blood disseminated disease. So we cannot consider this disease as a simple one because we have skin lesions and the disease is quite severe. A little bit about the epidemiology of AIDS in Brazil. We know that about 36,000 cases are diagnosed every year. That was true for the last 5 years. However, since 2013, we've had a decrease in the number of cases in all regions, as can be seen in this map from the Ministry of Health. In Rio Grande do Sul, we have a high AIDS detection rate. You can see here the average for Brazil, which is 14.1, and the average, our average of Rio Grande do Sul state, which is up there. We only lose to the state of Amazonas, Manaus, where I'm from, by the way. So in any case, I would have to be involved with that and with histoplasmosis as well. We can see here that 41.9 per every 100,000 inhabitants is the proportion of cases that we have in this city. Therefore, this shows indeed that we are in a place of high endemicity for this disease. In 2020, the highest AIDS death rate in Brazil was exactly here in the city of Porto Alegre. Much higher, 6-fold higher than the country rates, the death rates in Brazil, which is 4, and we are 24.1 for every 100,000 inhabitants. Tuberculosis and histoplasmosis. Well, my topic is to talk about co-infections. People living with HIV and TB, these are the recommendations. They should receive a prompt diagnosis. They should start antiretroviral therapy as soon as possible. We have to pay attention to interactions between antiretroviral therapies and itraconazole. We have to pay attention to the interactions of rifampicin and itraconazole, and many times we do that, especially today. Now we use it for patients of low income in our country. We use dexacolate, unfortunately, in spite of all the effects shown here, but we learned how to manage. And I think throughout the years, we've learned this management for persons who, patients who need rifampicin with tuberculosis. We still have a day hospital doing maintenance twice a week for the cases in which it's impossible to use itraconazole. We need to take into account and check the toxicity of itraconazole in the blood. We should consider changing rifampicin for replacing it for rifabutin. We need with the toxicities and interactions every day in our everyday work. When I was preparing for the Pascoloco trial, we started to look at histoplasmosis in a new way. And the years before, we had done a master's thesis on the same topic. And once again now, and it's sad for me to see that my chart of 2021 up to 2021 is exactly the same as that of the chart back in the 90s. So to us, we continue to see AIDS as we used to in the past. We have a few interesting things here that you can see, and I will speak more in depth about it, but most people are women. The majority is white because our population in Rio Grande do Sul, we have a majority of white descendants. And the main place of lesions, the main site of lesions was the skin when histoplasmosis was diagnosed. Second comes the lungs, and then we have the other sites: lymph nodes, central nervous systems, GI tract, bone marrow. One case with a lesion on the penis. And we will see here that the CD4 level is very low. Patients come to our hospital with a very severe and advanced immunosuppression. You will see that we had 6 deaths. Out of these 6 deaths, 2 cases were very impacting because they were children with vertical transmission of HIV, children who did not have support. The parents had died years earlier. They live in foster homes and family members who don't take care of these children, and unfortunately their immunosuppression is followed by a very high viral resistance profile. And in this case, these are concurrent infections, very severe and deadly. So among the comorbidities, the main one was cytomegalovirus, the main comorbidity with histoplasmosis. Second comes TB. Then we had pneumocystosis, toxoplasmosis of the central nervous system. And here we have the multiple ones: cryptococcosis with tuberculosis, actinomycosis with cryptococcosis and candidemia. So the opportunistic infections really in these cases are multiple, concurrent, and fatal. We have 2 interesting cases here. One patient who was admitted with COVID at 60 years of age and had a meningoencephalitis, and in spite of all the COVID management, he could never wake up. He was transferred to infectology. There they diagnosed HIV, and he had the meningoencephalitis due to histoplasma. So this is proven with a CSF culture. We had 3 more patients with COVID, and COVID was the less important problem. It was the infection that was the infection that was really making these cases severe was histoplasmosis. We had 4 cases of iris, which is known to be very not very frequent or probable, but in these cases we had iris, and where I used whether it's iris, I here included the initial CD4, which was 4, and then 85. All iris cases had an initial CD4 and the later CD4. These patients had other opportunistic infections in the beginning of the antiretroviral therapy, and they developed iris. And there is one more case, which was histoplasma already and recurred. Here I did an analysis. I included the period in which we studied these cases. We had 31 cases of HIV patients with histoplasmosis. The predominance of women, 20 cases, white race, average age 43, varying from 19 to 78. Main site was the skin. 19 patients had skin lesions, 61.3%, then mucosa, oropharynx, and other sites as demonstrated here. The main co-infection was cytomegalovirus with 14 patients, 45%, and TB, 32% co-infections with tuberculosis. We had 4 cases of iris. The CD4 average was very, very low. Many times I play around with the residents and we say, well, if we add up all of our CD4s, we do not achieve 100. So it is really a very dramatic situations. The main diagnosis was silver staining. 17 patients had a culture, and only 2 patients who were enrolled in the study had a urine antigen detection test. Unfortunately, we had 6 deaths, 19.4% out of the 31 patients, and 2 patients with vertical transmission of HIV. Cutaneous histoplasmosis, and I dedicated myself to it a long time, studying it and trying to teach and make our residents think of histoplasmosis. It does not have a typical form. You will see in some of the cases I will show it varies from papules, ulcers, crusts, ulcers, purpura, like lesions. So there is not a typical pattern. All HIV patients with any type of skin lesion, we are forced to think about histoplasmosis if we think about when living in our region. Another region here, crusty papules. This patient had some lesions that were suggestive of purpura. We have to insist and think about histoplasmosis. This is a summary of this discussion. Patients with vertical transmission, the death cases, the 14 cases that had cytomegalovirus, patient with COVID, patients with the immune reconstitution syndrome, iris, and the advanced immunosuppression is what favors the presentation of multiple comorbidities. We have to have a lot of criteria and a lot of caution in starting treatment, knowing the interactions and wait for these patients to have an improvement in spite of everything. So the main message is, yes, we do need faster, more efficient tests. Imagine with all of the difficulty doing all the step-by-step of the diagnosis of patients with histoplasmosis, the culture takes long, there's high diagnostic suspicion, we have to do biopsy. All that could be minimized if we had the urine antigen for all. So first thing, urine antigen for all. Secondly, liposomal amphotericin. It will decrease mortality, it will improve the treatment time, and certainly will improve the survival of our patients. Thank you.
Thank you. Now I'll ask all 6 speakers. Dr. Eduardo Prince had to leave to catch a flight. So all the other speakers, please. So questions, comments? I think you should use a microphone because there are many people online. I'm from Recife. I have 2 questions. The first one, in French Guiana, is it do they have so many cases there because they use antigens? Because I think that if we also have antigen available, we will have many more cases. But the question is, can we have the 3 amphotericin Bs used? Do each one of them have a specific role? Is the oxycolate still good for something? Because I consider it as a poison only. But when does the lipid complex formulation has an impact and the liposomal has an impact, should I use or have both, or is one of these formulations enough? I think we can start from your last question. In my view, that's not the case. We have no room for that. I think that amphotericin deoxycholate in ideal situations of pressure and funding resources, no, I don't think there is a role in for deoxycholate. We shouldn't be offering a drug that is knowingly more toxic and we do not know who will tolerate it. But this is in the ideal world. Now, considering resources and funds and the situation in many hospitals in Brazil, we should try to select patients with less risk factors, younger patients with no previous renal disease, who will not use another nephrotoxic drug together. But sometimes it's hard to find this kind of patient, but maybe for these population, if you don't have any resources available, maybe we could go on using amphotericin B deoxycholate. Other than that, I think in all other situations, liposomal formulation could replace it, because I don't see any advantage of the lipid complex compared to the liposomal formulation. There is this issue of lung penetration that has been advocated by some, but that's only in animal models. We treat aspergillosis and other infections in the lungs with liposomal formulation, 3 milligrams a kilo, no problem. So I don't see any reason why we should use the lipid complex formulation, unless you have resources issues or when we have no other formulation available. I'll just insist on that point. There is a tradition here of neglecting toxicity. You commonly reduce the dose of amphotericin B deoxycholate. It's like having staph aureus sepsis. You treat it, then you have toxicity, and you just continue for 2 days or give them half the dose. We do that. That's why we have survival differences when you compare studies that are powered enough for mortality. You do have different in mortality. That's for aspergillosis, because reducing dose of a drug that you need that given dose to be effective, it means that you're not treating the patient properly. Of course, I understand it. I have a hospital with a deficit of 350 million Brazilian reals. It's a big crisis, but we can invest in looking at costs and not just price. Front data were interesting. She showed how many patients were on dialysis when being treated on amphotericin B. I think this is underestimated. This was not a study where we really used stringent criteria regarding what is toxicity. This is just what the attending doctor declared. But if you have the right numbers, 120 patients, how many went on dialysis? 10% on dialysis. This pays the bill of the other, taking the lipid complex formulation. So we have to work on costs and not price. The other question regarding antigens, or the comment you made, pediatricians use the oxycolate. So if you look at guidelines for candidemia in children, they love it because it has good penetration in the CNS, it goes better to the urine, and sepsis in preterm babies, you have this issue. So pediatricians, I think they have a slightly different view from us who work with adults. Antigen, I showed that piece of data on purpose. Of course, there's a tropism that is different between the different histoplasm strains distributed all over the world. But what people from French Guinea showed is that they have their late diagnosis. This is fungemia with many, many lesions. That's really a shame. They should be we should be embarrassed to see patients with that amount of lesions. We should blush. This is late diagnosis, entropism. And people from Guinea show that if you use antigen testing, not only they have 10, they reduce mortality because they have early diagnosis. I'd like to make a comment to Felipe. The snapshot shown by Fran regarding histoplasmosis showed that the vast majority of patients were HIV positive, and due to that fact, they couldn't get a lipid formulation, or if the state paid, but the state government gave them, not the Ministry of Health. I don't know if Zenide has a new piece of information, if HIV positive patients will one day be able to get the lipid formulation, because it doesn't make sense. Those who need it most, those who really need a lipid complex formulation, which are patients who are HIV positive and have histoplasmosis, they didn't have the right to get this medication. But France's study, this was different, wasn't it? Just to add to what Dr. Felipe asked, if there is any difference between these different amphotericin B formulations, what we see in the literature, they talk about therapeutic equivalence between liposomal and lipid complex, but pharmacokinetic is not really the same. That's why we have differences in dose in terms of milligrams per kilo, but we still need more studies for the amphotericin B lipid complex formulation. There are really some gaps. We don't have many studies, for instance, regarding the CNS. That's why we have more robust or more studies on amphotericin B liposomal formulation. I agree. We shouldn't just be looking at price, but here in Brazil, the difference is really huge. 30 to 3,000 Brazilian reals for one dose. And something I presented, I forgot to show you, is that even though the average, the real number of days on use was 2 weeks, 2 weeks treatment, following the guidelines, but when we look at the different formulations, this really varies. The oxycolate from 13 to 62 days of treatment. lipid complex formulation a little less. That's interesting because we really have to know this so that we have a clear view of what is really going on. Looking at our reality here, I was really outraged with a recent report by the Brazilian Ministry of Health stating that liposomal amphotericin B will be given for mucormycosis and for cryptococcosis. But why not provide this to histoplasmosis that is much more endemic, that causes many more deaths in HIV-positive patients? When I heard that, I thought, no, I want liposomal amphotericin B also to be made available to patients with histoplasmosis. Once again, I'll try to explain, but at first, you being outraged, you shouldn't really be outraged. You should be satisfied or pleased with the fact that we could meet the needs of people for at least 2 diseases. This is an ongoing process. In the short term, we intend to meet the needs of all people living with HIV. I mentioned that yesterday, but I understand that the fact that we can already meet the needs of people living with HIV in 2 diseases that are very severe. I'm not minimizing the severity of the other diseases, but the impact today. I said, for us to be able to meet the needs of these patients, as Dr. Tudela showed, we have to know what the reality is. And today, we have over 1,500 cases of cryptococcal meningitis reported, whereas the AIDS program gives me an estimate of histoplasmosis cases of 6 cases a year. So we have to work with the data we have, the data that are available. I understand you being outraged, but I would like to make it clear that the possibility of having reached these patients with cryptococcal meningitis and people living with HIV, that was a big gain. I think that we are used to criticizing some issues that should be, we know what is behind that, the difficulties we face, but we should always value the real gains we have achieved, considering a situation that is still very bad. I would just like to make that clear. It's a process. We are working to meet all the needs of all these people living with HIV, but for that, we need a movement, a national movement from all of you here, so that you give more visibility to fungal diseases. We have no notification. We are based on systems that actually are not according to our reality. We depend on administrators who do not understand or do not see fungal diseases as diseases that should be notifiable diseases, so that we have a public policy. I would just like to highlight that. I was really happy to expand the medications for mucormycosis and cryptococcal meningitis in these patients. On the other hand, I'm sad to see that colleagues didn't see that as a benefit, but they were disappointed, outraged with this report by the Ministry of Health. Okay? Good morning. I'm Claudilson from Bahia. Just a curiosity. amphotericin B deoxycholate, this is not a Brazilian problem, right? This is a world problem, Africa, Asia. And amphotericin B deoxycholate, I understand with this change, it's an old elderly person, I don't know how, 60 years. It was so useful for so many years that I think we should be thankful for the fact that we had it available, but it's not the main thing right now. Just a comment now regarding azoles, these new azole drugs. Maybe Colombo can answer that question. Are there any studies for these new azoles? Because of cost. Because the oxycolate, the cost is $199. These new azoles, are they as efficient as Ambisome, for example? I think we should touch on these issues. I think it all has to do with the transparency you discuss with society regarding the choices you make. If we look at the speed with which you add new technologies in different areas for cancer treatment, hepatitis, HIV, and in mycology, you will come to the conclusion that it's not just a matter of numbers. It's a matter of choices made by administrators. I understand with the fact that you were outraged, because for many years I heard that it was impossible to buy liposomal amphotericin B because this was a price for a disease, leishmaniasis, that we wouldn't be able to do that in a fungal disease, that we couldn't have another lipid formulation. So listening to society, listening to the players, discuss with them clearly, telling them the resources available and talking about your priorities, I think people wouldn't be so outraged if we did that. I see people working with virology. I think they are much happier than mycologists. And if you look at the cost of their programs or our programs, we see that you have resources for one program and not money for another program. How much does a transplant cost? Government invests in transplant. How much? 100,000 Brazilian reals. 80,000 for a transplant. And then there's individual gets an infection and will be treated with amphotericin B deoxycholate, and they will die. We have data for that. So Brazil needs to be revisited in its transparency. Brazil has to have technicians revisiting these priorities. Brazil needs to be serious in the actions it takes so that the money is worth more regarding what society needs. I don't really agree that amphotericin is the same issue everywhere in the world. In the places or in the countries that have people really managing health with transparency and professionally, this has been changed. Terezinha? Also related to what Arnaldo is mentioning, I agree with you. Since we have people online, maybe we have many students listening to us, I think it's important to say that amphotericin B really played its role. It's been very important for a time. I like the fact that it's an elderly lady and maybe it's about time for this drug to retire. Maybe this is what we want. I recall at the time I have Caletra. It saved many lives, but it's a drug that is very hard to use. And when it left the market, I said, well, it was about time. Then a colleague said, no, but it's been very important. And it was indeed, but it was a very hard drug for the patient to comply with. I think that the same thing happens with amphotericin B deoxycholate. It has played an extremely important role. Many years ago, we had a meeting in Suriname. It was the first meeting with gathering people working with histoplasmosis. And that time, they didn't have histoplasmosis B. They didn't have even deoxycholate to treat patients with histoplasmosis. we have to consider that Brazil is a huge country, so we have very different realities in different areas of Brazil. In some places, they don't even have amphotericin B deoxycholate. In many places, it was not available. In Brazil, this should happen in some places. I'd like to make another comment regarding what Adelaide said. I recall that some time ago at São José Hospital, we didn't have enough antiretrovirus. So we ran out of antiretrovirus. Then a representative from the Ministry of Health came to our hospital and said, you know, what the notifications we have in Ceará, patients living with HIV is that. So we sent the amount of drugs to treat this number of patients you are reporting, you are notifying. So I think that we now, with this provocation by Adelaide, that we don't give visibility to histoplasmosis, let's do it. Goiânia, Ceará, Natal. Let's check in our state. I think in Guyana, histoplasmosis is already a notifiable disease, isn't it? But let's give it greater visibility. And we have to do something. The Ministry of Health has to see histoplasmosis as a serious disease that it is. I think we have to leave here with a proposal. And after this comment, can I ask a question? I'm worried with time. We'll have a session at the end of the meeting where we can discuss these issues. I'll ask this question later. Leaving aside the political philosophical conclusions, I'd just like to relate to this comment you made regarding other antifungals, because we are in a meeting of histoplasmosis, which is histoplasma is an endemic fungus, and endemic fungi are very sensitive. In addition to amphotericin B, we have new triazoles. We have few cases treated that responded very well to this new azole, but nobody's doing research or clinical researches with larger number with salvoconazole, posaconazole. You cannot say because we have only the oral solution available in Brazil, but it's an active drug as a new preparation of itraconazole, subaconazole, which we don't have, oleurophene, which we don't have in Brazil yet. So I think we have to look ahead, look forward, looking at new drugs for the treatment of this endemic mycosis. It seems that the world has stopped on amphotericin B and itraconazole. I hope that in 5 years, when I'm retired, you will be discussing the new drugs. We cannot just stick to amphotericin, which is already 60 years old, and itraconazole, that is already around 40 years old. Well, this is my point of view. I would just like to make a very brief comment on the discussion on amphotericin B deoxycholate. We, in fact, had to adapt to a damage reduction work. There's evidence showing that efficacy is similar, but safety is better for the lipid complex formulation. But if my patient with histoplasmosis will have to be treated with amphotericin B deoxycholate in Brazil, this is the reality today. And I think we have to look at the care we take during infusion. So hydration, preemptive replacement of potassium, magnesium, monitoring 3 times a week. These will reduce by at least 50% discontinuation of treatment. And this has been shown in lower income countries. And the experience of Emilio Ribas Hospital with flucytosine and deoxycholate in the first 2 weeks of the induction treatment for cryptococcosis, toxicity-related discontinuation was 20%, 10% for each drug, but lethality was 5% in 2 weeks. I think this sense of reality, we have to take it forward because this is how we have to work today. Unfortunately, we already have lipid complex formulation. Patients are started being treated with amphotericin B lipid complex. So things will improve, but it's still far from ending. We have to take care with nephrotoxicity and other events. I would just like to say that, and 2 quick questions to the panelists. First, we always work with fixed, set treatment time, 2 weeks treatment. I think this should be looked on a case-by-case basis. Maybe one patient will need 1 week and then de-escalate for an oral formulation, or in other patients, you may have a longer induction therapy time. I think that's important. Treatment times are just for reference. And another question regarding screening of patients with very low CD4 count levels, for those who see patients in the ward or outpatient clinic, we do antigen on a regular basis or routinely for Cryptococcus. So, screening strategy for all those patients admitted, or look at clinical manifestations, because this will, of course, depend if it's in a endemic or hyper-endemic area. But sometimes we do have a surprise. We have a positive antigen, and it may be a less severe case, similar to CMV, where we, as a routine, ask for PCR, blood CPR. But I think we have to look at each case individually. I'll answer regarding this antigen testing, regarding screening of asymptomatic patients. It's not clear for me. I think we should have more data in order really to know what the screening strategy should be for asymptomatic patients and what to do with the patient if it's positive. Should we do preemptive treatment or not? But I don't think we have an answer for that. Now, in a patient who is admitted to a hospital, I think that since this is a non-specific disease, patient is admitted for a given cause, I think it's you justify doing that antigen testing, because it may relate the condition that led the patient to be admitted to this disease. I think that's it. I fully agree with what you said regarding the oxycolate, because it's the only weapon we have in our armamentarium. Unfortunately, it's not like math. For how long will patients receive it? It depends very much on the severity of the disease. We have to personalize treatment and learn management. So this is what we have been doing for years now. We dream and we really wish we had a less toxic treatment, a quicker treatment, new drugs. This is the goal. But meanwhile, our reality is personalized treatment. Guidelines say 2 weeks. I doubt if a patient with CD4 count of 4, disseminated histoplasmosis, that we will discontinue treatment after 2 weeks. You know, it will not take just 2 weeks. So treatment has to be personalized. I'd like to make a comment regarding screening. I think that we have to look at it very carefully. One of the most important reasons for screening is that if you don't do screening and if only look at clinical data, you miss co-infections, unless if it's someone who is really experienced. Unfortunately, in fungal diseases, many people are not trained, do not have the expertise, so there's a lot of noise. Many clinicians don't even consider a fungal disease, even though fungal diseases are important. For instance, in HIV patients in Guatemala, people didn't even think about fungal disease. They thought that it was all TB, and then they realized that it was TB or a fungal disease. You don't have to do it everywhere. You may have a given hospital where you have expert infectious disease physicians, and you have another hospital where people don't really know anything about it. And we have to look at it carefully. But one important piece of data, with 20%, In Guatemala, it's 17%. 17 or around 20% of co-infections, if you do not do screening, you will miss them. You will not diagnose one of the diseases. You'll be treating just one, and patient may die because of the other disease. And TB, in the end, well, in the end, everybody will die of a heart attack, and we don't know what the burden of disease is. And on top of that, just to reinforce what you've just said, detecting one and treat just one, also the unnecessary treatment, because of the 220, we have 360 we received amphotericin B, and the vast majority of cases, the oxycolate. So this individual possibly didn't have histoplasmosis, were treated for a long time. We should also consider that when we think about how important the screening is. I'd like to ask a question, but a comment before. I'm really happy to be watching you and listening to what you say and listening to what Marineide had to say. I did my residency with Breno and Marineide, and Marineide had already done a master program, master thesis with histoplasmosis. Everything started there when I was her resident. I'm very concerned in the co-infection, TB and histoplasmosis. I was part of the WHO guideline, and the recommendation was, in co-infection, prioritize TB. And I didn't agree with that, because I don't know if it's the best choice really to prioritize TB. What do we do with histoplasmosis if we give them amphotericin twice a week? I think that was not really good. I don't know what your view is. What is the best management when you have co-infection?
Infelizmente, nós temos muito.
Unfortunately, we have many TB cases and histoplasmosis, and many cases treated empirically as TB that do not get better are actually histoplasmosis. In my master thesis, as Pascoaloto mentioned, I think it was around 25% of patients treated empirically as having TB at that time didn't get better, and they had actually histoplasmosis. And here, in many of those cases, we had patients with mycobacterial tuberculosis in the culture, Mycobacterium avio intracellular in a different culture, and histoplasmosis also in culture. So the concomitant infections, that's the challenge. We have decided to keep them on amphotericin for as long as possible. If there is no renal failure, if the patient do not get worse regarding their renal function, often when these patients come with multiple comorbidities, either they discontinue antiretroviral drugs and they have a viral resistance. They have a profile of antiretroviral resistance in genotyping that is also challenging. So often they will have to go to a second line for TB treatment with many more drugs, also with their own toxicities, and then things get much more complicated. But at least they will go to a second line of treatment, and then you can have maintenance therapy with itraconazole. But we do not really know what the proper therapeutic level is for itraconazole. We don't have like the proper serum level for itraconazole. So often what really makes them improve is improvement in their immunity if we give them the right antiretroviral regimen to rescue them. And as their immunity gets better, we then are able to remove the suppressive therapies. In the case of histoplasmosis, we shortened the time of not being 1 year in suppression therapy, but depending on the CD4 count level and non-detectable load, if we get it right with an antiviral regimen that will rescue these patients. Thank you, Marineide. Before I give the floor to Cássia for the last objective comment and question, because we are already late and we have questions from the chat. Cássia. Very quickly. In a hyperendemic area, I think it's important. We've been through that. We have a culture of thinking in histoplasmosis, and what is more serious for us is that 40% of our patients have a diagnosis of HIV with advanced disease, with CMV infection. We have low TB infection in these patients. So the important thing is quick diagnosis. And since we don't have access, unless when we have a research, our team starts empirical treatment with amphotericin B. And these are severely ill patients, pantocytopenic patients with co-infections. I think it's become even more serious now with COVID-19. It is as if time had not passed. I see patients coming with advanced AIDS and educated people. And I say, how come you've lost 20 kilos? Didn't you think about HIV? Our new concern is quick diagnosis or early diagnosis so that we can start treating them faster. Sometimes they already come with kidney problems. We just want time so that we can start treatment as soon as possible, as early as possible. So it's really important to be able to advance with dissemination of data. I believe that this is not a reality in a hospital with 121 beds. It is not. I think this is all over Brazil. This is a reality all over Brazil. And we have to advance and do whatever it takes to get the resources. What is the best way? We want to advance. This is my goal in life. So have something really to change this reality. I can no longer take it. We had more questions, but due to the time constraints, I'll ask just one question. Marcia Mello asked the following question: what is the role of isaconazole? Is it already approved? And what about the IV formulation? I think I can answer that question because I was part of the Vital study that looked at efficacy of isavuconazole in rare fungi and endemic diseases. This was published in CID a few years ago. Around 6 patients with histoplasmosis were included, in addition to coccidioidomycosis, cryptococcosis, paracoccidioidomycosis, and all histoplasmosis patients responded, but it was a very small number of patients. After that, I do not know if there are other studies with isavuconazole. Isavuconazole has good penetration in the CNS. It's very safe, few drug interactions. I think it's a potential candidate. It's a pity that its cost is very high. It's very expensive, except for a few exceptions to use it in public health. But I think it's a drug that has a potential to be used to treat this disease. A question, Bactrin's question from yesterday, the question was on transplant, particularly kidney transplant, prophylaxis with Bactrin. Does it prevent histoplasmosis in these patients, considering that it covers histoplasmosis? I showed data about the suboptimal role of voriconazole and fluconazole. Bactrin isn't really that good. I don't think this is really enough. And effectively, we have kidney transplant patients, and we have many, largest number of histoplasmosis patients, I would say that it's not very probable that this is something interesting. Regarding drugs, I think we have to invest in drugs that do not cause many drug-to-drug interactions. That's clear. If you look at the pipeline for new antifungals, there's a myriad of antifungals being developed that do not show a lot of interaction with other drugs. So oral drug, not much drug-to-drug interaction. Regarding the first drugs, first line, hardly we will have something better than the best amphotericin formulation we have today. I wish that the healthcare system understood that providing us the best early antiretroviral antigen and liposomal amphotericin B. This is what we need to meet the needs and to really change the natural history of histoplasmosis. Other than that, we'll be talking about amphotericin widows, of something we do trying to solve toxicity. We will be working with alternatives which are not the things we really need. It's important to mention that I came here to change reality. If I come here just to use regimens to reduce toxicity of amphotericin B deoxycholate, I think I didn't really do what I should. Okay, thank you all very much. We'll have a break now. At 3, this will be very interesting, a table on histoplasmosis and public health, where all the things we couldn't discuss will be discussed there. See you. So in Rio, this is the place where I come from, this has been one of the main diseases. We have had many patients with acute histoplasmosis, even in our offices, both in the private and public healthcare system. We have seen many cases in Rio. We say that we are controlled by bats, pigeons, and so we have to live with all these fungal diseases. Our first lecture this afternoon will be by Dr. Juan Tudela, founder of the reference lab on medical mycology, Instituto Salud Carlos III, and he worked as a member of many different international associations, past president of the Committee on Susceptibility Tests with the European Committee on Antimicrobial Susceptibility Testing, and member of PAHO in the Antifungal Resistance Surveillance Network in Latin America. He will talk about decodifying TB-like fungal diseases, histoplasmosis.
What lesson we learned there? We learned a lot of things, especially I learned a lot of things. And this is the second paper we published with new HIV patients. And the first conclusion is, for the first time, a public health program giving access to the diagnosis decreased the mortality. In 1 year, we decreased the mortality in 7% and increased the opportunistic infection treatment by 5.1%. I think this is a major advance for Guatemala. This is one of the issues that I want to discuss. I don't know if we are going to have a discussion after the presentation, but that is something for me very worrisome. We did an analysis because the recommendation of the WHO, the recommendation on advanced HIV disease, absolutely arbitrary. They have decided advanced disease is 200, but we wanted to know how many infections you diagnose by the numbers CD4 count. And as you can see here, with less than 100, you diagnose, the sensitivity is 66% and the specificity is 75%. If you test less than 200, the sensitivity is increasing and the specificity decrease. And with less than 350, you get almost 95% of the infections, but the specificity is very low. You have to test a lot of people to diagnose an infection. But for us, I think you have to go for 350, because otherwise you lose 10% of the infections. And I think they are life-threatening infections, and you can miss life-threatening infections. So I think we can discuss after, but for us, the threshold for CD4 count should be 350. You can see you have a 2.4 and 1.5 infection between 200 and 350, and even you have some infection with people above 350. Then the reason why we screen everybody regardless of the CD4 count is because in Guatemala only 80% of the people have CD4 count before their screening. So we did that approach because otherwise 20% of the people we never screened them. And other two things quite important for us was the people in Guatemala reached diagnosis really, really late. 52% of the population get the diagnosis with less than 200 CD4. So it's a very distressing situation, and 77.2% get the diagnosis with less than 350. And well, even you have again infections with people with above 350 CD4 count. Well, let's now summarize what we have found in Guatemala about histoplasmosis. And this is the last paper we published, this incidence of histoplasmosis in a cohort for an estimation to reality. And these are two works. Medina is one of the ladies from Guatemala. She did the work in 2017, and this is the Danish paper that has been shown many times in this meeting, and all of them, the estimation are pretty the same. But our estimation is double. The real estimation in Guatemala is double. When you test people, when you screen people, the incidence is double, 7.4%. And you have 1,523 more cases every single year. So it's the change from the estimation to reality is quite big. In addition, I have told this before, 15.6% of people had co-infections, and these are the co-infections. The most common one is histoplasmosis plus tuberculosis, 57%, histo plus crypto, 30%, histomas non-tuberculosis mycobacteria, 9%, and a three guys with a triple infection. This is the incidences according to the number of CD4 counts, and you can see for people with less than 50, histoplasmosis is much more frequent than tuberculosis, and the rates are quite high. That's the reason why I suggest that you have to screen people less than 50 for tuberculosis and histoplasmosis. And then, well, histoplasmosis decrease, but you have always in all the CD4 counts, you have numbers of histo and tuberculosis. And what about the diagnosed performance for histo? Well, the diagnosed performance for histo is the culture is very low. Guatemala hands. The isolator is not very good, but it's good. The PCR works pretty well, but the best one is urine antigen by ELISA test. And the second one is unit combinations to get all the cases diagnosed. Unit combination of urine antigen plus PCR or urine antigen plus isolator plus PCR plus culture. So this is an idea. Just one technique is not going to give you the answer for all the people, and that's quite important from the point of view of the screening power of the lab screen. When we arrived at Guatemala, everything was tuberculosis. When they see this, what is this? I can't believe that I have made such a mistake. And then they study, and the next time they always thinking tuberculosis and histo. And this is the proof. This says the number of people that we screened in 2017, 2018, and 2019. more and more people screen and more histoplasmosis diagnosed. So the people were much more worried about the patients, and they demand diagnosis to the central laboratory. The screening increases to treatment. All of the groups were at the beginning in 2017. The treatment was much lower than when we finished the study. The mortality is quite high, but for us it's quite important. Mortality is very quick. You need to diagnose the people really quick. Otherwise, the people are going to die. So you cannot send this to a reference laboratory and wait for a test for 1 week. You need to get the results in the same day. And finally, screening decreases mortality in general, but you have also some kind of surprises like this on I think people believes that as the guys on antiretroviral therapy, they are safe and they don't treat it, because I don't understand this for this in the second year. But in general, we got decrease in mortality. And finally, what I have put this morning, this figure, and I think without diagnosis medicine is witchcraft, but with a vertical approach is fake news. Absolutely. So I think we need horizontal programs or screening programs for very sick HIV. And these are my last recommendation. Diagnostic laboratory hubs can accelerate access to diagnosis, horizontal diagnosis programs for patients at risk, and if you set up a diagnostic laboratory hub, you need a good delivery system for clinical samples and a quick turnaround time. I think this is key. In my opinion, I think you should screen for histo and tuberculosis. They are difficult to differentiate clinically and frequent infections. Antigen detection is key, absolutely key. I think for me is the new gold standard, but you need other techniques to get all the patients. Antibody, PCR, isolator of others. And burden of the disease is the first step, but we cannot, I insist, we cannot lose patient histories, and we need big data for fight factor. And that's all. Thank you very much.
Obrigado, Dr. Juan. Bom, agora vamos para a segunda parte, a segunda palestra, que é do Dr. Fred Pérez, assessor de pesquisa em doenças transmissíveis da Organização Pan-Americana de Saúde e Advisor Communicable Disease Research da PARO. Ele vai falar o que a PARO tem realizado em relação à histoplasmose. Fred.
Buenas tardes. Me han pedido que también hable en inglés. I'm going to speak also in English. So good afternoon to all of you. First of all, I would like to thank Alexandra for inviting PARO to be part of this meeting. So I'm going to, in the next 15 minutes, I'm going to be giving some descriptions of what PARO has been doing linked to histoplasmosis. So, but I would like to first of all highlight some of the core functions that PARO has in the region of the Americas, and linking a few of those core functions to the activities of histoplasmosis. So you see, if we highlight the shaping of the research agenda and looking how we can apply the knowledge of the research agenda in the region, now I'm going to show you what we've been doing linked to this first core function. Number two is the issue of establishing technical cooperation with countries. And PARO does this mainly with ministries of health. And three is the issue of looking at setting norms and standards. So much has been said yesterday and today about the guidelines. So this is a good example of norms and standards that we've been coordinating. But before getting into more detail of histoplasmosis, some context. And here, just to highlight, this is the classic cascade of HIV in Latin America, the latest. And just to highlight the challenges that we have from testing to adults who are positive on treatment to the adults living with HIV who are virus suppression. So you see in each of the steps, a very high challenging to be able to get a better coverage. And this is linked also to the next, this has been also discussed, but this is showing the last data, 2020 in Latin America, showing percentage of people living with HIV with a CD4 less than 200. So you see countries like Paraguay that I've highlighted here because I'll be showing some preliminary data that we have from Paraguay, and of course also Brazil that we are here now. So for us in PAHO, this is one of the challenging data to see what we can do. Now, why is this important about late HIV diagnosis? And we have mentioned this frequently yesterday and today, is early mortality, of course, high incidence of co-infections, as we said, increased risk of loss to follow-up on the patients. We need to move into the more programmatic aspect. And here, one of the high challenges is, of course, loss to follow-up of patients. And something else that I would like to highlight is the issue of cost. Increased cost of care that was mentioned this morning for patients. So you see, these are the links of why it is important and what needs to be done. Now, to finish this first part of the context is look to your right, the percentage of patients AIDS death related. We have decreased this in the last years in the region, but there is much more to do because one of our goals in 2020 was to have 19,000. And so you see, this is a big challenge that we still have. Now, of course, we need to discuss opportunistic infection. This is data from one country in French Guinea that shows, of course, disseminated histoplasmosis is the key opportunistic infections in this country. We can see this, and it's been shown in Guatemala and other countries of the region, the importance of disseminated histoplasmosis as an opportunistic infection. So, based on all that context, and with the support of CDC and other colleagues, and many of you who have been here experts, have been helping to put the guidelines that PAHO coordinated in 2020. How has this been done? Of course, using meta-analysis, systematic reviews, not only on what we have been discussing of the importance of the antigen detection and the sensibility specificity, but also on treatment and the importance. This is the basics, the systematic review also that helped us put the recommendations in the guidelines. I'm not going to go into the detail about the specific recommendations that you all know, but these are the recommendations that came up linked to diagnostic, to treatment, and also linked to time of antiviral initiation and in the link about TB therapy. So you see the first rule of PAHO linked to norms and standards when we talk about histoplasmosis. But the issue is the norms is one thing, but what came out of that also, the challenges about, so here I highlight some of the key knowledges and gaps linked to the recent guidelines. The first one I think that we have not discussed too much here is how are we going to be adapting these guidelines to the health systems of the countries at different levels of the health system, primary, secondary, and also reference hospitals. Two, the issue of the impact of rapid ARV initiation linked to that. The lack of CD4 access, which is in some countries a very high priority. And finally, what focus are we going to be giving to specific populations, key populations, and the diagnostic networks that was discussed also previously. Here, of course, based on that, we all know, we have the rapid tests, the rapid diagnostic assays that we are using, and we are using or recommending in the countries for histoplasmosis, for crypto, for TB. Of course, you know the sensibility, specificity, and the pricing. A big challenge for the country is going to be the pricing of these tests. So another rule for PAHO is a department that we have, which is called the Strategic Fund, that's going to be helping, that is helping countries in the procurement of tests and drugs. So this is a platform that we have to improve the affordability, the availability, and the quality of the test and the procurement. And just recently, we have been able to include many of these tests that you see in red are now included in the strategic fund of PAHO. So you see another role linked to the topic is to help countries procure the testing. I'm going to move faster. We see the essential diagnostics medicines that are included also in the WHO list. So based on this context, what we also do is support ministries of health in the programs. And one issue is research for implementation, which means how are we going to be able to improve the programs in the ministries of health, doing operational research, doing research for implementation. And an example is the work that we're doing with many colleagues that are here, ministries of health of Paraguay mainly, is to look at this implementation research project for the incidence and mortality of crypto, histo, and tuberculosis in people living with HIV in Paraguay. As background, you see Paraguay, you see here we have this distribution of diagnosis according to CD4 cut. More than 44% less than 200 for male and female. So high priority. So this operational research project had as general objective to determine the incidence of histoplasmosis, crypto, and tuberculosis using rapid diagnosis in people living with HIV, advanced disease, and calculate mortality at 30 days, with specific objectives to determine the incidence of these opportunities of infection linked to specific categorization of patients with CD4 counts less than 350, and regardless of, and also with patients symptomatic regardless of CD4 count, and determine the 30-day mortality with these patients. This is like a generic frame of how we are working with the countries. First, we are preparing, we have a generic protocol that we help countries adapt to their specific context. And one of the main issues is helping them procure the test, procurement of the test, and then working with the national program to collect the data and training of doctors, nurses, and laboratory staff. Here is an example for Paraguay, the patient stratification in 2 groups. As of now, we have recruited 368 patients in the 2 different groups here, people living with HIV without antiretroviral therapy, with specific CD4 count, and in another group with symptomatic people living with HIV regardless of heart and CD4 count. This is the basic monitoring that the national program is doing in Paraguay, with a recruitment, a weekly follow-up and recruitment that we have done till, this is data till the end of April. And you see, this is very preliminary data that shows that from 368 patients, we have antigen histoplasmosis positivity of 10%, of antigen cryptocosis of 12%, TB, when we're in TB, based on TB gene expert or TB LAM, we have, or 15 or 19% respectively. So you see a high prevalence of these opportunistic infections in Paraguay. And also to highlight that one of every 3 patients has an opportunistic infection. If we look on down, and also to highlight that the most important combination of infectious disease has been TB and histo, as you see there. So this preliminary data is showing us also the mortality at 11%. So with this information, as of now, the Ministry of Health has decided to expand the program, not only in the capital city, but at national level. So this is an example of how a demonstration project can help the Ministry of Health expand coverage of health in the country. So conclusions, the first preliminary conclusions of this program, 1 of every 3 patients is tested, which has been tested is positive. The implementation of rapid tests impact on case detection. Rapid and accurate diagnosis can reduce mortality in people living with HIV. And also, we are now helping them doing a longitudinal follow-up to look at the cost of the implementation of this package of services. A second country where we are working with the Ministry of Health is Trinidad and Tobago. This is still, we have not started recruitment yet, but just to show you another geographical context where it's not only one laboratory, but based on the geographic of Trinidad and Tobago, we are including 5 sites. And also the challenging of the networking of the laboratory in 5 sites. So these 2 examples, as was mentioned, to how we can help to get to the targets of the Manaus Declaration that we all know here. To finalize, other ongoing activities that are very complementary to these 2 implementation projects that we have is we are starting to work on a cost-effectiveness evaluation for the implementation of urine antigen testing in Latin America, based on the examples of these implementation projects. 2, we are here also, we hope to soon start working in 2 sites here in Porto Alegre. And we are also, something important is to try to do mixed evaluations where we include not only the monitoring of the data that I mentioned, but also qualitative data. What is the perception of physicians, of patients? So including in the evaluation, qualitative evaluations. And finally, we are working on an e-learning course on advanced HIV disease that will be out around August, September this year. Thank you very much.
Obrigado. Nosso terceiro speaker é
Third speaker, Dr. Cáceres, infectious disease doctor, expert in diagnostics, epidemiology, identification of fungal disease, worked in the Corporación por Identificación Biológicas, Medellín, Colombia, working with technology transfer, assessment of specific reagents for histoplasmosis, diagnosis in a cohort of HIV patients in a hospital in Medellín, Colombia, and he's going to be talking about implementing antigen testing in Latin America.
Okay, so today I'm going to tell a history. So first of all, I would like to say thank you for the invitation. And for me, it's a special honor to have the opportunity to tell this history today. So I hope you enjoyed it. Okay, so these are my disclaimers. So I would like to start this presentation with this question. And what is impossible? So in the 18th century, it was impossible to see everything beyond what the eyes could perceive, no? And then we developed the microscope, and we had the opportunity to see more, no? And this and discover all the micro, the bacteria and all these tiny world, no? Less than a century ago, it was impossible to go to the space, and now we are thinking about commercial flights to the space, no? And about 3 decades ago, it was impossible to have an histoplasma test, no? And now we are having some kits commercially available that are facilitating the diagnosis of histoplasmosis. Okay, so we don't know histoplasma before 1906, where the first case was described in Panama. And during so many years, most of the people think about histoplasmosis as a disease just limited to some endemic regions in the Americas. So now we know that histoplasmosis is spread around the world. And again, the question, what is impossible, no? Okay, so talking about this history, I am going to tell you about the evolution of the different antigen tests for histoplasmosis. And in addition, all the process for transferring and implementation of these technologies across the Americas. Yesterday, Diego did a great summary about the evolution of the different antigen tests. So it's important to highlight that Dr. Joe Witt in Mira Vista in Indianapolis, in the United States, developed the first antigen detection test based in a radioimmunoassay in 1986. No? Then in 1997, there was some new approaches. So Dr. Beatriz Gomez and her team in Colombia developed reagents for the detection of antigenemia. This was the first time that someone developed reagents for antigen detection outside the United States. And Mira Vista also improves their antigen detection assay, just transferring this from a RIA to an ELISA. No? Later, in 2007, CDC started all this effort for the development of the specific regions for the diagnosis of histoplasmosis by antigen detection. So in 2007, Marlene Sid and the group of people on CDC developed these first regions for antigen detection. And in addition, IMI, as Diego mentioned yesterday, released the first commercial kit for detection of histoplasma antigen. This first kit was based in a polyclonal antibody ELISA, and that first prototype or that first product has a sensitivity around 70%. Okay, so I would like to make a special mention in 2009. I think 2009 was a starting point for a lot of the implementations in the Americas. So in 2009, again, the group of the CDCs published the first transfer of this region developed in 2007. So this first implementation was done in Guatemala. And personally, I think this is the beginning of the history of implementation in Latin America. So I'm going to talking about a little bit the protocol 4250 and other technology transfer that happens in the region. And I would like to say that this is going to be the first part of this test implementation. Using the in-house ELISA developed by CDC in 2009, that ELISA used a polyclonal antibody with a specificity around 86%. So after that first implementation in Guatemala, so CDC supported the transfer of those specific regions to other countries in Latin America. So CDC practically support the implementation of this test in Central America and Guatemala, El Salvador, and Honduras. Later in Colombia, also I had the honor to be trained and I had the opportunity to use ELISA, this ELISA for a couple of years, the Guyana Shield, and also Brazil. So I would like to summarize what we learned about this protocol. No? So first thing that I would like to highlight, so now we know that rapid tests reduce mortality. And this is the experience or one of the experience from Guatemala early during the implementation of the CDC protocol. So practically what they found in Guatemala is a significant reduction of mortality when patients are tested using antigen tests. Second, another experience from Central America as part of the implementation of this test. This is a protocol that was carried out in El Salvador and Guatemala. And practically what we learned is the testing increased the chance of surveillance or survival, sorry, independently of the result. In addition, in Colombia, we had the opportunity to implement rapid access and education for histoplasmosis. And what we observed after this implementation is that practically in this laboratory, so practically what we found on this experience in Colombia is after the implementation of rapid tests and other technologies as molecular testing, there is a significant increase in the number of cases of histoplasmosis detected. We also know that novel tests reduce the turnaround for results. This is another experience from Colombia. So practically what we did here is we compared the turnaround time for results between conventional testing, practically based in culture and even serology, in comparison with molecular and antigen tests. So what we also is that the turnaround for results is shorter when it's using those technologies based in antigen and molecular detection. And another important aspect that we had the opportunity to get from this protocol is the biorepositories. And this is one point that Juan Luis commented this morning, no? Is the capacity to generate biobanks. So those biobanks are going to be useful to develop and validate novel technologies. So that's another important aspect of this experience in Latin America. Okay, but we had a crisis in 2015. The crisis was associated because those reagents get all, it was an in-house ELISA. There was some issues about reagents production, and practically there was 2 countries running the test as a routine test, one place in Guatemala and another in Colombia. Unfortunately, that situation happened, but at the same time, IMI released a new product, a 2nd generation ELISA, the ELISA that now is commercially available, because we had in Guatemala and Colombia the specimen from the protocol 4250, we were able to rapidly validate and implement these new commercial kits in those 2 laboratories. So I would like to highlight here the close work we had with IMI during this validation, and also we had the opportunity to improve the technology, reducing the number of reagents required in order to reduce also expenses associated with the testing. So the phase 2 is going to be more that transition from in-house testing to commercial kits. So since 2016, CDC started the implementation and the transfer of these technologies mostly in Central America. So here there is an experience that was done in Panama, Honduras, and Nicaragua. As part of this technology transfer, we realized that 1 out of any 10 patients tested by cryptococcal antigen tested positive. And in the case of histoplasmosis, we got a positivity ratio of 20%. Another experience from Guatemala, Juan Luis presented the results very well early. So practically they did this implementation of facilitated testing in Guatemala across the whole country. And practically they found that 60% of people tested positive for any opportunistic infection. And also histoplasma was the most frequent infection. They also compared the performance of different diagnostics, and they realized that antigen test has the best performance, and in addition, near to 1/3 of patients will be missed in case of don't use the antigen test. Another implementation from Brazil, this is a study that was carried out between 2016 and 2018. Very similar results to the implementation in other countries. They implement rapid tests that increase the number of cases identified. They found a lot of people positive for histoplasmosis, and in addition, a lot of co-infections. And more recently, I would like to highlight this study that was recently published. It's another experience from here, from Brazil, in Rio Grande. So as you see this morning, practically the results of this implementation was an increase of 300% of cases after the implementation of rapid testing. So, just talking about the future, I would like to say that maybe the phase 3 of this implementation is going to be more related with point of care testing. No? Now we know that ELISAs and antigen tests are working well and having good performance and increases the number of cases. So now we need to do that implementation, that testing where the patient is. No? And here is when, again, we would like to highlight this new development. There is a lateral flow antigen test that practically use urine. As you see in the presentation yesterday, this test has a really good performance. This is awareness and advocacy. I would like to highlight the International Histoplasmosis Advocacy Group. Most attenders are part of this group. And as you see, this is a group that is growing, growing, and growing. No? So here's some pictures. Here is just to track the implementation of this antigen test in the region. As Freddie mentioned.
About the care of people with advanced HIV in Brazil. Good afternoon, everyone. I would like to congratulate Pascoaloto on this great meeting, all the professors who were here, extremely high level conference, and unfortunately Dr. Beatriz Kaminski couldn't be here because of health reasons, so we will replace her as the I will be the spokesperson of the presentation that she presented. I have made a few changes to her slides. We are talking, therefore, on behalf of the program, on behalf of Dr. Gelson Pereira, Dr. Ana Cristina, and Dr. Beatriz, who unfortunately couldn't attend this meeting. Well, it's very clear. It's clear to you what the concept of advanced disease and HIV infection is. I'm not going to repeat it, but many times we have to bear in mind that we need to pay attention to some signs which may be close to the sepsis sign, high respiratory rate, high cardiac rate, the possibility of ambulating without help, high fever in a clinical context which suggests a severe clinical condition are suggestive signs that given the high mortality that it causes. We see it very frequently in our setting, both in the context of late diagnosis, and I will bring some data to you. So this is a mission that we have, which is quite important to avoid late diagnosis, thus increasing the early screening of these cases. On the other hand, we have a large number of patients who abandon treatment in our services, and this requires an active search, a team which actively does this search in order to avoid this unfavorable situation, and a group of patients who are under virological failure, probably due to multiple resistances or resistance to antiretroviral therapies. This meta-analysis is well known to all of you. It was published in 2015. It assessed several trials worldwide with thousands of inclusions, and it became clear that the most important death causes were those that had to do with the AIDS definition, especially tuberculosis, but also toxoplasmosis, and the systemic mycosis also appear in an important way. We could not but mention severe bacterial infections in these populations, invasive infections, bacterial sepsis, which have a big contribution as well. In Brazil, we have the same challenges. As I've said, we have an abandonment rate, a dropout rate, which is very significant. It's greater in some states than in another, and the Ministry of Health has been monitoring these data frequently. Therefore, we need proactive actions in the active search of these people who have abandoned treatment. This piece of data is highly worrisome. It's been shown in this meeting at different times, but if we look at the year 2020, in the early diagnosis of HIV infection, 28% of the individuals had a CD4 lower than 200. This is extremely worrying. because it characterizes an advanced disease situation. We have some locations in Brazil where it can reach 40%. So if we have an estimate of about 35,000 new notifications a year, we will be talking about more than 10,000 people every year with an advanced disease diagnosis. This graph shows a coefficient of admission, hospital admission in these patients. Of course, not all of them are admitted because of AIDS-related diseases, but most of them is. So it's very clear that this leads to a morbidity and mortality, and there's a high cost, extremely high cost to the healthcare system. I bring here a good news. The program is implementing this project. It's a demonstrative project which aims at caring for these people with advanced disease. The main objectives of the project are to reduce mortality and morbidity, also to offer prophylaxis and preemptive treatment, and the rapid start of ART, if possible, and for these patients, as well as an expansion with regards to the knowledge of this topic and the recognition of advanced disease by healthcare professionals at all levels of healthcare, from basic care, primary care, to the specialized care, to the tertiary care, to the ICUs, even where these patients many times arrive with a high mortality. Also to improve adherence of these patients to healthcare service, and not only adherence, but keeping them in treatment in the long term. This is a demonstrative project in process. It will be demonstrated in 5 states that have been chosen, per region. There's specific resource for this project, and this project includes the placement of point-of-care CD4 tests, which is an extremely important step to recognize these individuals with advanced disease, and other tests that are done in the point of care to detect tuberculosis, cryptococcosis, and blood, and CSF detection as well. And also, we have also included in this demonstrative project the antigen for histo and urine. This project has an outpatient approach as well as an intra-hospital approach with all of these actions that I've mentioned to you, prioritizing these patients with an advanced diagnosis. The preparations for that have already started about a month and a half ago, and we will have the first meeting with the managers of these 5 states now by the month of May. By the end of the month of May, it will be a 2-day meeting during which we will discuss the foundations of this project with the managers and with the other interlocutors from different states. From June to August, we have planned training of healthcare workers and professionals in these states. Then in August, we expect the inputs, the tests, and from then on, we will begin monitoring data and the process will progress. Considerations. Well, the purpose, the objective of this project, it is a demonstrative project that has been done in other countries, and we aim to broaden it to all of the country. I would like to thank you for your attention, and if I may, I can answer the questions on behalf of our organization.
do Ministério da Saúde, que é médica, especialista em doenças infecciosas da Secretaria de Saúde do Distrito Federal, é consultora e prestadora de serviço técnico da Organização Pan-Americana de Saúde, junto com o Ministério da Saúde, na área de vigilâncias das doenças de transmissão respiratória e imunopreveníveis. Ela vai falar sobre as estratégias de incorporação dos testes diagnósticos rápidos em micologia no Brasil. Obrigado.
Boa tarde, e queria agradecer mais uma vez.
Good afternoon. Once again, I'd like to thank Pasqualotto for the opportunity to be here talking about surveillance and control of endemic mycosis. Just a small correction. I'm no longer with the Department of Surveillance of Immunopreventable Diseases. Now I am in the Department of Sexually Transmittable Communicable Diseases and AIDS and Preventable Chronic Diseases. So I'll give you an overview of the strategies for the incorporation of rapid diagnostic tests in mycology in Brazil. So, as I could already say before in this meeting, this issue of data on mycosis, we know that fungal infections in tropical regions are totally neglected. Now, regarding national data on endemic mycosis, well, we do not have these data because they are not notifiable diseases. We have some challenges for the implementation of programs and health policies, and what we have been considering over all these years we have been tackling this issue. We can highlight a few issues that are really key in this process. Main difficulties are lack of knowledge on the part of managers of the morbidity and mortality of fungal infections in Brazil. Another difficulty is lack of knowledge by healthcare workers about the clinical manifestations and epidemiological conditions when treating these fungal infections. Also, lack of active surveillance of mycosis with ignorance and unawareness of the actual data regarding incidence and prevalence of fungal diseases. Another difficulty, well, we have thousands of difficulties, but these are the main ones. Lack of a specific laboratory diagnostic network. So in an attempt to implement a surveillance system for fungal diseases, the main objective of the surveillance system would be to develop a surveillance system to determine the magnitude of infections. We mentioned that earlier today. We do not have data. We do not know what happens exactly in our country. And in order to really be able to implement this fungal disease surveillance program and set public policies, our specific objectives are estimate the prevalence and geographic distribution of endemic mycosis, estimate mortality rates for each of these fungal diseases, make early diagnosis and treat cases timely and appropriately, detect and control outbreaks using prevention and control measures, and always promote technical and scientific development in the area, making new diagnoses, introducing new drugs as part of the list of drugs available, so that we can work in a specific healthcare system. And in order for us to be able to implement the surveillance system, many actions are needed, and among these actions, we have actions that have to be taken simultaneously. Human resources training, doctors, radiologists, pathologists, lab technicians. Also develop a surveillance system, as I said before. We are right now developing a surveillance system for fungal diseases, and the pilot will start operating next August, a pilot, and also diagnostic network, including infrastructure, equipment, collection of materials, transportation of samples, diagnostic procedures, and procurement of supplies, and a care network, primary care network, a hospital network, clinical management, and availability of medications. So these are all actions that have to be worked on simultaneously so that we are really able to implement them all. In 2010, 2011, we already trained many lab technicians, physicians, surveillance technicians, but unfortunately, that didn't work. It was kind of fragmented, many lab technicians, and that's a major issue we have, which is high turnaround rates of these professionals in the public service. So we lost all these lab technicians who were trained back then. But anyway, we are working now simultaneously on all those systems so that we can really have a system in place for the surveillance of fungal diseases. In 2021, we set a few priorities. One of them was to construct or develop this information system where we're going to not make it not mandatory to, well, we wanted fungal diseases, to be part of the notifiable disease list. So with this system, we would connect notification of the disease to the release of the medication or dispensing of the antifungals, training of health workers for surveillance and treatment of fungal diseases. We will have 2 distant education courses to implement continuous education. These are 2 courses. One specific course is for clinical management for physicians, and another course for laboratory technicians, so focusing on laboratory diagnosis. So this is distance learning, and we chose this model because these distance education courses can reach more people. And well, by the way, last week Roseli was in Brasilia training 11 different labs. So they were taking this training to improve laboratory testing and diagnosis. So this diagnostic network, which includes LACEN, reference hospitals, they had this training, so 11 LACENs were trained. Another modality we established as a priority, another priority, was preparing the clinical and therapeutic protocols. In 2021, we prepared clinical protocols for paracoccidiomycosis, histoplasmosis, cryptococcosis, porotrichosis. So they were put together, developed, and right now they are being reviewed and updated for publication. We proposed the inclusion of new antifungals because today we have only amphotericin B lipid complex and itraconazole. So we've proposed last year, we managed procitozin also ready to be incorporated. That was last month. We took new proposals to Conitec, and we had the approval for the incorporation of Anidalufungin, voriconazole, isovudicol, and expansion of the use of liposomal amphotericin B. So we had these 4 proposals that were presented, approved. They are now in public hearing, and I'd like to ask you to say something, because it's really important that you all participate. So after this consultation, if it's once again approved, because it had a first approval, we shall then buy these medications still for this year. Flucytosine, that was approved last year, we had a problem with flucytosine importation. We are importing it through PAHO, and PAHO has a way of procuring drugs and where the company has to be qualified. And the company that is qualified by PAHO to produce or to sell flucytosine couldn't really meet our demands, but it seems that this issue has already been solved. So soon we will have flucytosine available here in Brazil. So the main developments we had in 2021, which were our priorities, was the inclusion in RENAME, which is the National Essential Medicines Network, so inclusion of flucytosine, also incorporation of cryptococcal antigen, LFA, for all people living with HIV, particularly those with CD4 count less than 200, and a new agreement for the care of people living with HIV with cryptococcal meningitis or mucormycosis. Earlier today, some colleagues didn't really agree with that, but we see this as a strategy, because it's important that you all know that the Ministry of Health today, we from the area of fungal diseases, we don't see HIV patients because of a legal requirement. So an agreement was made between the 3 powers, city administration, state government, and federal administration. And in this agreement, according to this agreement, every HIV patient, the federal government would be responsible for making antivirals dispensation. So the federal government would provide medication for HIV patients, antiretrovirals, and the state government would supply medication for infections. That's why we, the federal government, do not do that. So we, after we changed department, particularly after we changed department, now we are in the same department where you have the AIDS committee together with Hanseníase. We started to do a more integrated work, and we've asked that we started taking care of all infections, opportunistic infections, fungal infections in people living with HIV. In order for that to happen, we needed to have a tripartite meeting with different organizations, including the Ministry of Health, to look at that request. This requires a lot of planning to assess the economic impact in terms of procurement of medications. And then we had lack of data on fungal diseases in people living with HIV. The only data we managed to find were those on cryptococcal meningitis. And why? Because the meningitis program, well, meningitis is a notifiable disease. So we inferred that through meningitis notification, we would get data on cryptococcal meningitis. And this is what we got. An estimate was calculated, and this was a disease for which we had data to present, unlike other diseases. So we calculated this budget impact that is required when you ask for a new drug to be part of this list. And then we included these two diseases, mucormycosis. We shouldn't question it because cases of this disease are very serious, causing a lot of impact. So we got medication for this disease. I thought it would be something that shouldn't generate any kind of outrage compared to other diseases. This was a gain for patients. It was a personal gain of ours because of the struggle we have had very clearly, very transparently to mitigate the damage caused to people with this disease. So this is what we got. And in 2022, inclusion of anidafungin after this public hearing is completed, so that we start buying these medications. And for the next city meeting, we have already an agenda so that we can really provide drugs for the treatment of all fungal diseases in people living with HIV. This is a process, it takes long. We will request the inclusion of ELISA for histoplasmosis, urine, aspergillosis, which is Achilles heel for us. We have a hard time assessing the cases because we do not have diagnosis. So we have to have clinical, radiological assessment. We are working to implement new diagnostic tests. Tests that will be procured 2022-23 are ELISA. This is being requested by the General Coordination of Public Health Labs, SEJA-LAB. They have already put together this report, because for you to understand, you cannot just go there and ask for this drug to be supplied. We have to write a justification why you are asking this drug to be included on the list. You have to present evidence, references on the efficacy of the test, a number of issues. All this has to be presented. Then this goes to CONITEC. CONITEC technicians will in turn perform an economic impact study, because you have to present the statistics, what is the estimated number of cases of that disease, and you have to say for how long you will be treating the patient. This was discussed earlier today. We will treat for 2 weeks. We usually increase the number of days because we have to look at that on a case-by-case basis. And we see that in practice because drugs are not decentralized. We look at it on a case-by-case basis. SEJA-LAB has already started this process to be taken to CONITEC meeting. Well, CONITEC determines when there is availability to assess this request.
So these two, both ELISA for histoplasma or the other one for aspergillosis, has been forwarded. And we, from the Coordination of Chronic Diseases, we are discussing, and we've had a practical, conceptual issue there that tests which do not involve medical equipment are not dealt with at the level of the coordination of public health labs. So we are now the rapid test for us at the TB coordination, AIDS and mycobacteriosis, not tuberculosis, mycobacteriosis. We have taken upon ourselves this purchase, and we've been this procurement. We have been discussing about what the target group will be, what the estimate would be, point of care tests. Because some people think point of care should stay with LACE, but no, point of care should stay in the hospital at bedside. These are technical issues that we have to work with, and we've been working specifically for these two tests. Well, as a perspective then, we are structuring a network of care based on clinical epidemiological diagnosis of systemic opportunistic mycosis. It is our goal, perspective is irrestricted access to antifungal agents, which will be made available, to structure a diagnostic network in order to ensure access to the diagnosis of mycological conditions, also histoculture, so serum tests, and all of the states of the federation. Point of care access to PVHIV, to PLHIVs, mainly those with CD4 lower than 200, to train healthcare professionals in the clinical and epidemiological management of fungal infections in this distance learning format, and to try to implement surveillance of mycosis in all of the states of Brazil by the end of 2023. Thank you very much. We are available for any clarification. Thank you, Dr. Adelaide. Well, before I make my remarks, I'm going to call to the stage, because we have now a long time for discussion. I'd like to call Dr. Flávio Teles, Dr. Terezinha. I don't think Mari Neide is here anymore, but Dr. Cássia Godoy, Mônica Bailey, Sandra Damasceno, Diego Falsi, to take part in this discussion. And our discussion is basically about strategies for what everyone wants, for what everyone we all work for, to save lives in Brazil, and here more specifically histoplasmosis. While people head to the stage here, I'm going to make some comments. We've had in the last 2 days a big discussion about histoplasmosis from epidemiological aspects, advances in diagnosis and therapy and treatment. And now we have a big discussion as to how we can implement this, what the gains will be that we will have of these implementations in partnership with PAHO and the Ministry of Health, obviously involving the state secretaries and municipal secretaries, CONASES, CONASEMs. These are important partners for us to achieve gains. Dr. Adelaide presented here several achievements. Speakers too, all of the speakers. Dr. Adelaide presented here the gains that the Ministry of Health has brought, the advances that it has brought, the achievements. We have to always congratulate these initiatives. Dr. Adelaide, me as a manager, I've been managing the university hospital in the last 4 years, and I know very well what you were talking about. I know we want people will be happy, and then somebody will ask a little bit more, but that's how it is. We are used to that. Right, Paulo? We have been used to an AIDS program, which has always been recognized internationally as a program of excellence, and we would like to extend this to all diseases. Obviously, we always want a little more, and this is the reason why we are gathered here, in order for us to be able to help SBI, and I make SBI available to help the ministry, the department, in whatever is necessary, technically speaking, for us to move forward in that regard. When I began the presentation, the introduction of this panel, I mentioned how histoplasmosis has increased its incidence, its prevalence. It's a disease that we ever more see in Brazil, in our cities, in our city, this city here as well. And it certainly has to do with what's happening worldwide. We are invading the natural habitat of many of these animals, invading forests and the woods, and well, then we get in contact with these diseases, animal transmitted diseases, and histoplasmosis is one of these fungal diseases. I saw here a tribute to Dr. Angela Restrepo and also Dr. Bodovanki. He was the one who taught me about fungus, histoplasmosis, a professional that I acknowledge very much, one of the pioneers in the study of histoplasmosis at Fiocruz, who unfortunately passed away during the COVID pandemic. One more important loss. But it is a fungus that ever more increases its incidence, especially in immunodepressed patients, HIV patients. It's very difficult. We have now some time for discussion. I open the floor for Q&A as well, even comments, Arnaldo, Diego, all the ones at the table here, or for those who are online for following us.
Pode vir. Ué, a gente pega a cadeira aqui. O problema é cadeira, né? Não falta cadeira aqui. Bota ali. É. Bota mais um aí. Pronto. Eu fico aqui no canto. Perguntas?
Bom, pessoal, tendo feito todo esse evento, todos esses dias, ontem e hoje de discussão, a questão técnica me parece bem posta.
Okay, after all these days, technically, we've had technical discussions, but now we have to talk about how we do it in practice, how we improve access to medications, how we provide patients with diagnostic tests, the difficulties that exist in the ministry. How does this become a reality, this world, access to histoplasma, antigen, and rhizome? How can we have access, embosome, to all these? I think in face of the difficulties that Adelaide brought us regarding diseases being incorporated as notifiable by the Ministry of Health, what we could do and determine as a result of this meeting is for each one of us to intervene with his or her own state to try to implement this in the Secretary of Health, like Cássia has, for this to become a state notification. And this could be a piece of data used by the very Ministry of Health to try to claim tests, medications, and other interventions that we seek when we deal with histoplasmosis. I would like to add to what has been said here and to say that in my understanding, these initiatives that we have, they are part of our confrontation of the HIV epidemic. I understand that we have to join what has been done with HIV in order for us to provide a proper response, because we have many patients with the COVID pandemic, this became worse. with late diagnosis of HIV, with a low CD4, coming to the hospital already very ill, and these are our patients with histoplasmosis. Therefore, the response to histoplasmosis is part of the response to HIV, and it's key that we agree on that. And based on this, having a robust response to HIV, we can also tackle histoplasmosis and fight histoplasmosis. In the same line of thought, I would like to reinforce what has been said before. I don't know if it's something local. In Goiânia, it's been happening since 2013. So where will the ministry look for histoplasmosis? There is that notification form of patients with AIDS. I don't know what the reality is, but in São José, it is a reference hospital in Ceará. This form is filled out by a technician, and when the patient goes get the medication, the pharmacy only will dispense the medication if that form is filled out by a nurse or technician. That part that has to do with opportunistic diseases, they don't know. So proposal is, and I could even write it down, at each center we could rescue these forms. Somebody could do it, maybe a student, and try to fill out that section which has to do with opportunistic infections, because histoplasmosis is not there, and we need the Ministry of Health to see this. So my proposal here, and you have to help me see if this is feasible or not, Adelaide can help me see if it makes sense, but we could show them, well, this is our form, our patient's notification form, and the X amount of histoplasmosis is this. So and then the Ministry of Health will be able to visualize it. The problem with this file is that it is only going to reach those who open a diagnosis for histoplasmosis, Right, but the form is only filled out at the moment that the AIDS diagnosis is done. Not anymore. That's over. That was before. Now every HIV positive patient has a diagnosis. Ever since we began to treat all HIV positive patients, they need to be notified. Otherwise, they don't receive the medication. Yes, but I don't think you can open the form more than once when you include the AIDS criteria. If you re-notify a patient with AIDS, they pop up in your life out of nowhere. When he is again notified, it goes to the surveillance system. When the surveillance system enters SINA, they bring together the files and qualifies the information. So it would be interesting when people don't open it, because why doesn't histoplasmosis appear in the notification system? Because it is not a notifiable disease by itself. And we notify our patients either with HIV, when we find HIV to notify, and most of them are not getting in as patients of HIV, or AIDS. And when we notify AIDS, and I've asked for the I wanted to check how we've been doing it in the last few years. So the 4 larger services in Florianópolis, out of 10 years of AIDS notification, in one of them we had 527 notifications, no record of histoplasmosis. The other 600 with 1 notification of histoplasmosis, the other 300 no record of histoplasmosis. So out of the 3,000 AIDS notifications in the last 10 years, we had 1 case of histoplasmosis notified together with AIDS. Why? Because nobody goes to the CDC criteria and includes it, even for patients who has a diagnosis of histoplasmosis. The crypto is agreeing because it gets into meningitis. So when there is the meningitis diagnosis, the files are matched. In the past, I think the only solution is what my friend here is saying, or we should notify everyone if you don't have access to the previous file, because the previous file you cannot have access to. You have to open a new file, and it has to be exactly the same name. If Luis has an S and he uses S in one file and Z in the other, they are two different files. This is what I meant. I know that once you close the notification, you cannot reopen it. So what you are suggesting is that there is some kind of duplicity, to generate some duplicity for the system to catch it. It's possible, just like you enter a data of meningitis, bacterial meningitis, to get into the AIDS and TB, differential diagnosis, whatever. Because it would use a pre-existing notification to include histoplasmosis. Sometimes I see a problem in notification because we only catch 40% of the patients with AIDS who open the file for histoplasmosis. The other ones will come later. They're not going to be re-notified, so we will not manage to do that. In Fortaleza, we have saved. I don't know about the reality of other centers. That's why I'm talking about Fortaleza. But in the São José Hospital, we have almost all patients in the last 10 years with histoplasmosis. So we take that number and that name, and based on the name, we can open the file. I'm going to do that in the São José Hospital. I'm going to take a master's student. This will be the master's dissertation of one student of mine, and I know which student I'm going to pick. I'm going to set up a meeting with him next week. So this is what he's going to do. We have, both of us, in the last 10 years, we haven't caught all of them because we don't have antigen, but from the last 10 years, we have patients with histoplasmosis. So we have several patients whose file we can identify through SINAM. We have their name, and then we can make this duplicity and then manage to filter it. This is what I'm going to do. I think overall, that's it. And in line with what you were saying, I think it would be possible for us to have some kind of organization from the Ministry of the Infectology, the Brazilian Society of Infectious Diseases, some investigator in the area like Pascoaloto, to make a retrospective assessment in sentinel centers to assess from the methodological point of view what the representation would be for each region or for each sector of the country, and to list some sentinel centers and make a retrospective assessment. It's not a very accurate piece of data, but it would certainly generate very valuable information for those who don't yet have the compulsory notification. And if there's somebody leading it, or Pascoaloto or another investigator, this information could then immediately happen and generate interventions. One other thing that perhaps could be important, in my opinion, is just like we would do it, would be in the same way to do it prospectively with the sentinel centers, in a prospective fashion, a study of detection, indeed, with a simple detection, but very well designed from the methodological point of view. Also with populational representation, a sample of the populational sample. And what happens many times is that in epidemics, those who show the diagnosis are the labs. We had an outbreak in São Paulo of hepatitis A in 2007, and those who notified the municipal secretary of health were the labs. They began to detect an exponential increase in the number of hepatitis A cases, and several actions were then done. So ultimately, LACEN and other sentinel centers could help the labs, could could cooperate, notifying positive results. These would be, well, information that we would have until the right moment comes to take action. I think, Paulo, this is a good suggestion, and we could even simplify this. Yesterday, we had data of histoplasmosis presented by several states and regions of Brazil. So we do have the data, and they are in the hands of several researchers and epidemiologists. Perhaps what we could do, because I understand Dr. Adelaide and the ministry saying that they don't have this data because it is not a notifiable disease. But much of this data is published, and what we can do is, and SBI could help us in that matter, is through the committee of mycology of SBI, and Fabio is the coordinator, the chair, to monitor, to take this data, to plot them somehow, and to forward them to the ministry, to forward an analysis of these data with the number of cases, the history of cases that we have in the country, and a regional occurrence and the prevalence in each of these regions, because it is an under-notified disease which could be faced as an important disease that should be looked at as a priority for the implementation, incorporation of new technologies. I think this is the easiest path, because if you look for notification, this is the path that many other diseases had. Vaccine, and well, we don't have the notification for many of the diseases that we have, which have a vaccine for in Brazil. So perhaps the easiest way, the shorter path, would be to take the data that already exists, to plot these data and forward them to the Ministry of Health with this request through SBI, in order for the ministry to officially have this knowledge, the knowledge of this data, and from then on to be able to present this to the manager and CONITEC to implement these technologies for the treatment and diagnosis of histoplasmosis more specifically.
Actually, this is not a question. I would just like to add something. I think we have to look to all databases we have. We have IHs that through diagnosis might tell us about cases. We have the issue of dispensing of amphotericin. So retrospectively, we have databases. Well, it takes some effort, but there are some ways to automate these connections between databases. And I think, this is my personal view, we have to take out of this meeting, so that from now on, we have these diagnoses notified, even though I understand that, be it at the state level or national level, we need a whole process. It takes a whole process to make this official and include these diseases as notifiable diseases, be it at the federal level or at the state level. But I think that the society is involved, be it infectious disease society, mycology society, or departments. I think we could define notification from the AIDS record, because the AIDS record, there you write histoplasmosis. See it to qualify those who have already been notified as AIDS cases who do not have histoplasmosis. We can notify it as AIDS from the, so we can notify histoplasmosis in the AIDS record from now on, for the future. I do not mean that one thing will exclude the other thing. That's not what I mean. Amphotericin B, I think this is a set of things that may take us somewhere, why we don't have these notifications. Within this set, and adding to what Paulo said, sentinel labs and so on, many patients stay in primary care centers for a long time. I don't know if we could implement that in primary care clinics. You can have presumptive diagnosis because often this is not a definite diagnosis. Then the health care professional should be able to say that it could be histoplasmosis, regardless of the result. And then we should encourage workup, not meaning that that's a definite diagnosis. I think we have to have that, and not just in sentinel hospitals. But I think it helps, and particularly in primary care clinics. This is what I see in Bahia. Sometimes patients are in a primary care clinic for days before they are referred to a major reference hospitals, and they are there without notification. If you allow me to intervene, I'll give my personal opinion, even though this is about your country. I think that all studies conducted in the continent have shown that histoplasmosis in a specific population with HIV, particularly those who are severely immunocompromised, is similar. It's virtually the same. Studies where new techniques have been included, around 30% of cases were missed before. So this is a disease which have to be diagnosed close to the patient. You cannot send samples to long distances because the patient, whether they get empirical treatment or they die, I think there is no other way out than provide access to diagnosis where patients are, where the commercially available techniques that work the same way everywhere in the world. When you provide access to diagnosis to all sites, all places where you have these patients, you will then really know what happens with this disease in your country, which is probably very similar, or maybe you have even more cases than the neighboring countries, because we usually have the same results in Argentina, the studies I've looked at, in Colombia, in Guatemala, in Paraguay. Freddie presented results. I don't really understand this discussion, whether we have to have more red tape. You should think about the patients, those who die, and provide access to diagnosis to healthcare workers, and then, only then, think about how to deal with this issue of data. I'm Prohaska from Recife. This is a major challenge, this issue of bureaucracy and red tape. And you may have 10, 12 patients and you have to fill out all that form. We had a previous experience regarding research work we conducted of a very practical questionnaire. And so we had like a integrated medical record. If you can have that, and then this being connected to one database, I think this is the best way to debureaucratize the service, because if not, we all have the same problem. We are few people, a lot of work, and many processes that are lost along the way. We have to unify information and try to understand the setting where the patient gets histoplasmosis. I think that in order to decrease bureaucracy, in order to overcome all the steps, we have to invest on that. How will this be made? That's a good way to consider and make this more practical. But this information has to reach the Ministry of Health. Otherwise, we will have meetings every 2 or every 3 years, and we will have the same problems. We have a hard time filling out documentation, because in some states this is notifiable, other states say they don't need because they have no fungal diseases in their state. And if it were not for the central program, the 330 patients we have of one particular fungal disease wouldn't get itraconazole. The 30 patients with disseminated disease wouldn't have got lipid complex formulation because they say that there is no fungal disease in the state. Now, filling out 350 forms and you have so many patients, you have to collect samples. If you don't make that more dynamic and if you don't unify information, centralize information, we will always be talking about the very same issues. We have that problem. And students change, but we stay there. The students move, but we are still there facing all this red tape. Taken related to that, Dr. Tudela, it's not bureaucracy for us to plan the number of tests we have to buy. We have to know what is the estimate of patients. So what we have to test, we know that this is what we want. But in order to plan procurement of these tests, we have to have an estimate of the number of cases. This is very complex. How we're going to get these numbers, as Dr. Shibabu suggested, how we will consolidate data that we already have, I think that's very important. It's a first step. SINAM is an extremely complex and stiff system. I don't know, at that time, we really asked to be part of this system, SINAM, and when we joined it and when we left, we had the first impact. So we were really disappointed at first, but I don't know if SINAM would really be the best system for us because it's kind of stiff. We'll make this try, the system connecting notification to release or approval of the drugs that will be made available. I think this is going to be a good tool, but it's not the optimal tool. I think that red tape, bureaucracy itself is needed. It is still needed. These are processes. Brazil is a huge country with different realities in different places, different geographical access. Just to give you an example, last week we had a technical meeting on lobomycosis. You don't even imagine the size of the problem, access, which medications. We don't even have medication to this disease. So this is all very complex. And if you add to that a huge country with diverse socioeconomic conditions, and we have to try to minimize difficulties and doing so homogeneously. As a proposal coming out of this meeting, I think this is really relevant. I think this meeting, I was in the Manaus meeting. A document was drafted there. We were not aware of the letter of Manaus. You know, the situation of these patients is so serious, they are not being taken care of. I agree that intervention for HIV treatment is a priority. And I think that we should have this document coming out of this meeting in Porto Alegre, and I think this should be officially sent to these government agency, SPS. And in the past meeting, I was not aware of that, because otherwise this will be a document that only those of us who are here will be aware of. We have to have this go to a higher level so that we can really work on the focus of the problem. I suggest you do this through the Brazilian Society of Infectious Diseases that has major representativity, so that we have a consolidation of already existing data. These are all very robust data, so that this is taken to the Department of Surveillance, requesting diagnosis, treatment, and care of these patients. Just adding to that, so you talked about this committee with this tripartite committee of administrators. We can submit this to CONASA and CONASEM, which are the committees of state and city health secretaries, and they also participate in the decision-making process regarding which drugs and diagnostic methods will be made available in the system. So, and what will the state be in charge of, and what will the Ministry of Health be in charge of? I think it's important that they too in this committee be aware of what was discussed here. I know that we need more data on histoplasmosis in Brazil. I think that in order to plan for procurement of drugs, we have to have numbers, but 40% of HIV patients in the hospital with fever have histoplasmosis. I know that in Guyana, it's 45%. I know that in Fortaleza, 40%, in Porto Alegre, is 8%. This already gives you an idea of the burden, the amount of disease we have in Brazil. And it's a lot. Even without notification, we do have data. Data are publicly available. The secretary is not aware of that. You know, but health secretaries are not aware of these figures. It's not going to be, as Dr. Adelaide said, it's not going to be through notification that we'll be able to get these data, because we know the difficulties. We are not able to notify COVID-19, which is the most prevalent disease right now in Brazil and in the world, and we have major under-notification of COVID-19. We know the hard time we had notifying COVID-19 in Brazil, so the data will have to come out through epidemiological data. So these data have already been presented today in Goiânia, Natal, in Porto Alegre, in Rio.
So we consolidate these data via the mycology committee of the SPI. We forward these data to these other agencies, and we have a good partnership with them already. And from then on, the ministry will have the data. And this will be our role, to demand from the ministry for them to take action for us to be able to implement this, both in diagnosis as well as in treatment. And once this is incorporated, then it's easier, because you will have the notification based on the drug. That is, to request the drug to treat histoplasmosis, you will need to have the notification, just like we do with all the other diseases, and then we'll have this feedback continuously. The problem with the AIDS file is that it is a portrait of that moment. So I notify at the time that I do the diagnosis. Not always does the patient have histoplasmosis. Then whatever they have will not be notified from now on, just like we do with Cryptococcus. But for the patient to have amphotericin, he will need to notify crypto. So the notification is that it is a portrait at the time of diagnosis. You only do notification once in your lifetime. Please. So I think there must be an effort on our side as doctors, and I'm talking about someone who's at all ends of the chain. I am a doctor and a manager, so we do have to raise awareness of everyone. The doctor has to qualify the file. As much as we have 15 visits to to see, patients to see, this is a great responsibility and we have to do it. The difficulty that we have in trying to justify a purchase or an extraordinary purchase, they ask for how many, for whom, and you say, no, you don't have an answer to give them. So how can you not know? Because on the files, then there is 0. You open Sinan and we see 9999999 ignored. This is the code. So there's no way. I think the society has this role to teach their peers and to say, let's do it right. I agree with you. It's not ideal. It's very bad, actually. And we were not going to change Sinan, Dr. Adelaide. We're not going to change it. You know it. For everything that we want to include there, it's a 10-year struggle. We have taken centuries to include the fact that the guy was a convict and we only knew he was a convict because of the address. And in Porto Alegre, we always knew who they were because they all came from the same address. So we know of the difficulties and limitations of the Ministry of Health in that regard. And we need to qualify that information by the professional who does the notification. I am fully convinced with Roberto's argument. I really think for you to rescue is very complicated. I'm going to already cancel the work from that student of mine. But I agree fully that with Roberto's argument. If you have done several studies in several hospitals, you can do a mathematical modeling with the data that you have with the HIV pandemic to know precisely the number, the confidence interval, if it's 500, 200, 1,000. And then with the mathematical modeling, this would be easy. You would have data for all of the country. What you need, well, and then you can see the treatment. So maybe, well, there's a price to it. So having these studies in the countries and with clear prevalence rates of on the incidence of histoplasmosis and HIV populations, do you have that? You can do a mathematical modeling that is very simple and get this data. I think we have all discussed histoplasmosis and AIDS here, but histoplasmosis is not only about AIDS. We know that in the US, the greatest incidence of disseminated histoplasmosis is not in AIDS patients, but in users of immunobiologicals. So I think it's a little dangerous for us to associate everything to the AIDS program, the patient who has or doesn't have AIDS. Histoplasmosis is greater than all of that. Felipe, he spoke very well about the risk, the population that uses immune biologicals to have not only histoplasmosis, but other mycosis. So this group should also broaden their view. So it's not only HIV, we have to notify the patients with the Sinan file, otherwise we'll lose many people. In Curitiba, in my hospital, at the Clínicas Hospital, more than half of the patients that we have with histoplasmosis are the users of immunobiologicals. They're not HIV patients, so let us not close our eyes, only AIDS, HIV. No, there are other populations as well, solid organ transplant patients, etc. Okay, now we're going to answer the answers in the chat box. Claudio Freire says, good afternoon. Congratulations on this meeting. I am Claudio Van Freire from São José Hospital in Fortaleza. Dr. Adelaide, do you think of any strategy to improve the deadline for the itraconazole and ILC? I know now it's 5 days. Perhaps we could think of a state drug distribution center. Claudevan, we have managed to reduce this delivery time. But and every request that comes is immediately analyzed, and we have until 11 o'clock, 11:30 to release the distribution agenda for the DAF. From then on, the order is released and sent to São Paulo, where we have the warehouse. And that is 5 days. We don't yet have a way to decentralize medications. At least high-cost medications, we have to control their distribution because the request of drugs for empirical treatment is huge. And I am sure that if we decentralize quickly, the drug will be consumed and we will not have medications available for those cases that are provenly diagnosed. The ideal thing would be for decentralization to occur. It's not a closed thing. We have to discuss strategies to centralize and expedite that. We know that 5 days until the medication arrives is a long time. And we have to assess that. And with this process, the implementation of surveillance systems, we will have to let go of some strategies, assigning responsibility to the municipal health secretaries to monitor this release. Like what do we do with leishmaniasis? We have to see how this is to be done. So it is our intention to really reduce this delivery time. And certainly for the states, this decentralization will be better, but we don't yet have a way to do it. Okay, in our hospital, usually we have more than one patient using amphotericin lipid complex. So the patient using it, well, by the time we have the approval by email, and this is quick, the approval takes place on the same day. We know that the medication will come to the new patient, and we don't wait. We take it from the patient who already has it in stock, and we use it for this other patient. If in a critical situation we cannot do that, then we start with amphotericin deoxycholate. Some cases are extremely severe, so I understand that we can solve that situation with of course, the pharmacy, the drugstore will be strict. That medication is for systemic mycosis and it should not be used for anything else. But within systemic mycosis, we will be using that stock as long as we have the approval and the next lot will come. Thank you, Suzanne Edinger. She says, this is a great meeting. Congratulations to all organizers. And she also talks about using technology in favor of that. There could be an app for notification. All you'd have to do is to do the notification at bedside. The thing is, one thing is for you to notify a suspected case and a confirmed case. For notification of a suspected case, you would have to return to have that confirmation of the diagnosis. So I don't know to what extent that could be done, because the diagnosis at bedside, if you already have a diagnosis, that's one thing. If there is no diagnosis yet, you need the time to have the diagnosis and then notify.
Isso é no Senam, isso é no Senam.
That's at Sinam.
É mais ou menos aquilo que a gente tinha falado, né, da ideia de que se dinamizasse essa
This is exactly what we were saying, the idea that we make this bureaucracy dynamic. We've done that with sporotrichosis to optimize treatment. Local treatment, there was an advantage. We did the documentation, and then it was sent to the epidemiological surveillance through the app. The surveillance would get in contact and take all the data, fill out the file, and this way we could identify sporotrichosis. We could identify the spread of sporotrichosis in the city of Recife. This was a great advantage in 2 years, because the city administration opened a team, set up a team with itraconazole, and for those who were not contemplated because they don't have a positive culture,
from the state of Ceará is here, and I think she will really be interested, isn't it, Karina? At least in Ceará, we will really be interested. Please do that. Send me an email saying how many strips you think you're going to be using a week or a month, so that we can do that for you. Thank you so much. Any further comments, questions? To add to this comment on Western blot for antibodies, the in-house tests, they, as an alternative, they may help change many things. We saw that in Colombia and Guatemala when we got this technology transfer from the CDC. But the difficulty is that the in-house tests are hard to implement. You have to set up very specialized labs. You have to have people who are dedicated to do that task. We have to mix like this, have to blend that way, have to do this, have to do it this way. So I think that prospects would be better to use this technology. And so it's better to have this technology, not just use in-house tests. I think we should have something more standardized as a kit, because it's easier to have mass production. It's easier to have a quality assessment. In-house tests run a greater risk of error. So kits would really be helpful to have all those control points, so that everyone would also work following the same scenario. And this would apply to molecular tests as well. We know that molecular tests have a good analytical performance, but there's a lack of protocols. Often, when a primer is changed, a reagent is changed, and if you do that, if you change a protocol or a reagent, the performance will change too. Then you say, okay, I don't get the same results as in that paper. Now, when a reagent in a kit, commercially available kit, is changed, a buffer is changed, the whole assay, the way the whole assay works also changes. Roberto? No one else? First of all, I'd like to thank you all for your participation. All this discussion was really great because we help each other. we find solutions. And once again, our society is available to the Ministry of Health, not only for histoplasmosis, but for all infectious diseases. The Brazilian Society of Infectious Diseases has participated a lot in with vaccines regarding COVID-19 and also now fungal diseases, HIV, and also bacterial resistance. And we are always available to help to advance medicine in Brazil. I'll give the floor to Pascoaloto to close and say a few words. Shortly, thank you so much for coming to Porto Alegre. Even those who are from Porto Alegre, we spent a whole Friday and a whole Saturday here. So thank you for those who come from far. It was a very busy schedule. I see, first, I was lucky to have this meeting after COVID, not after COVID, after a peak of the COVID-19 pandemic. Things are quieter now, and everybody really feels like meeting. And I think that was really good for the meeting. And the second theme is interesting. So it's nice to see so many people devoted to this very specific disease. I know that many of you suffer because you have many patients with histoplasmosis, but other people just study this subject, actually see HIV patients. And that was really cool. I'm really happy with the result of this meeting. I think the messages here are very clear. We have to increase diagnosis. The states and centers, when they started making diagnosis, the number of cases increased significantly. And you need diagnosis and early diagnosis using even antigen, no matter what method. It has to be available. We have to have access to better drugs. We still, even Said, we don't have it available for histoplasmosis and AIDS, but if we have liposomal amphotericin B, it would be so much better because it is the safest drug. And if this disease becomes a notifiable disease, everybody will see this disease. It will be diagnosed, seen, and treated, and then we'll have a much better outcome for our patients. I wish you all a good end of Saturday, and thank you all very much. Just a comment, Adelaide. I think you should invite him for the Ministry of Health, then you'll solve all your problems. I like Brasilia, you know.
Uma foto dos remanescentes, dos que ficaram até o fim, dos de fé. Estaría bueno